first and foremost is any deformities. Any deformities in the foot should do a proper clinical examination. The commonest predisposing factor is the heel varus deformity. It's called pes varus deformity, which is the commonest predisposing factor. Because of the heel varus, the lateral ligament will be continuous stress. So that's why you're going to get injured more. Next thing is always think of hyperlaxity, especially in the young patient, ladies. We have this hyperlaxity very commonly seen in many of the people. They will be asymptomatic, but still they have hyperlaxity. How we evaluate? All know with the venous story. That's how see. So hyperlax, the lumbar spine is flex so that she's keeping the hand onto the ground. Of course, it's very difficult for normal people, but hyperlaxity is possible. This is how we can touch the thumb onto the forearm, polar aspect. The third and rare cause or predisposing factor is the tarsal coalition. Coalition means an abnormal pitch between the tarsal bones. So it doesn't allow the joints to move, especially the subtalar joint. So that is another predisposing factor. The X-ray where we make stress view. This is the anterior droid test performed on table under anesthesia and image taken by CR. So we can see how much callus has shifted forward. Normally we should have ligaments are intact. So MRI always to document for the documentation purpose. We do MRI in all cases, especially during a microsurgical treatment. Not only for documentation but also to know other causes causing instability and also important. We can also make out if there is any osteochondral defect in the callus. And that's the advantage of taking an MRI. So, coming to the instability, there are two types of instability you should always remember. One is functional and the is mechanical. What is this functional instability? When the patient complains of instability symptoms, but however on a clinical examination, he won't feel any laxity of the ligament. Your anterior droid test will be negative. That's how we should suspect and label it as functional instability. And what are the causes? The causes are mainly the impaired progressive, thoroughly evaluated neurological status, neuromuscular control. Okay, and also don't forget the good things about the Achilles tendon, very important. The tightness of Achilles tendon. Okay, these are the causes for functional instability of the ankle, and the treatment is rehabilitation. We don't have much role. Okay, the next is the mechanical instability, where when the patient complains of instability and when clinical examination, the product is PD positive, and that happens because of actually trauma, tearing of the ligament. Okay, and also there will be some degenerative changes in the neighboring joints, and these are the patients where we consider surgical treatment. Coming to surgical treatment, we decide to go for surgery depending on the patient symptoms and examination. See that there's gross instability. We think of repair, and when we think of repair, we should know what are the types of repair. So just for a theoretical aspect, there are mainly three types. One is non-anatomic, anatomic, and anatomic with augmentation. So this non-anatomic repair is when we use medicine anatomy, like the parents previous tendon to reconstruct the ADF. But however, this technique is not so popular because it has got a lot of complications. And most of the surgeons worldwide prefer the anatomical repair where we restore the normal anatomy of the lateral ankle ligament complex. So this non-anatomic repair was initially popularized by Watson and Jones, where they used the peroneus brevis tendon, which was released and rerouted the fibula to reinforce the ADF ligament. But as I said, it has got a lot of complications and outcomes are really poor. So that's how the anatomical repair has popularized, and this being one of my favorite techniques as well. Again, in that there are a lot of techniques, out of which Rostrom is the first person to do this repair, and later it was modified by many persons. What we do here, so this is the modified Rostrom repair where with a small minimal incision for the lateral aspect of the ankle, we expose the torn ADF ligament, and it will get repaired by using a fiber wire by getting the tap. So thereby the ADF is repaired. This is another modification where we can see this is the ADF. So this is the ADF ligament which is very lax. That's why it is causing the instability. So what we do here, we repair either we repair directly and make it tight. Sometimes what is this? This is the inferior extensor retinaculum. This inferior extensor retinaculum has to be taken off and reinforced to the ADF. So it gives an extra support to the lateral complex. That's one of the modifications called by gold modification. So that's the technique where we do this. And there are some surgeons in the world where you get to arthroscopic. Anyway, I have got clinical experience with this. I always go open technique. So something called anatomic repair with augmentation. When we consider this, when augmentation means we always augment with some kind of material. Either it may be synthetic material like a tape, or it may be a natural one where we harvest a graft. Like one we do for ACL reconstruction. All of ACL repair reconstruction we take gracilis and hamstring tendon graft. Same thing we can take a gracilis graft here and reconstruct the ADF. That's called anatomic repair augmentation. And this has to be considered when actually the ADF is of very poor quality, and when the patient has got hyperlaxity syndrome by your Wheaton's criteria and obese highly ranked. And it is a revision case. Revision case means once the previous surgery has failed. These are the cases we think of augmenting. So that's suture tape application is one of the new evolving method where we use high molecular weight polyethylene material. So that's how. Now we move to the next another common problem is Achilles tendon disorders. Very important because Achilles tendon is one of the one of the strongest tendon in the body. Okay, and it is made up of, as I said, gastro and soleus complex. So, what are these Achilles tendon disorders? Mainly, you should remember of three things. One is Achilles tendinopathy and acute rupture and chronic rupture. These are the main three conditions which we commonly see with Achilles tendon. So, first thing we go for the tendinopathy. Achilles tendinopathy again is divided into two types. Insertional, when the pathology is at the site of insertion. Non-insertional, when it is 2 to 6 cm above the insertion. So, what is this non-insertional tendinosis or tendinopathy? So, coming to the etiology, again, we should think of predisposing factor. Again, it's common in Achilles because of repeated stress and strain is there under. And of course, there are other intrinsic factors like obesity, age, and extrinsic factors when they use steroids, especially we keep steroid injection to the tendon inside, that will lead to the problem and tendinopathy. Of course, the improper footwear, even improper footwear is one of the important factors. We see a lot of people, especially ladies, with improper footwear, they develop this tendinopathy. There are a lot of theory, mechanical and muscular theory for explaining the pathogenesis. So how do they present? They present with the pain, swelling, and functioning. It's called triad symptoms. So usually there will be a fusiform swelling just above the insertion. So 2 centimeters. This is the insertion. 2 centimeters above, you can see the lesion. So that's how you should suspect that it's a non-insertion tendinopathy. And evaluate with all the clinical examination or your silver scale test. There are so many tests. And X-ray, you can see there is a calcification. Can you see this mass, the bony mass? This is abnormal. This is the Achilles tendon area. You can see a calcified mass. That shows signs of degeneration. That's called calcific degeneration. And of course, your MRI shows a better picture. Of course, that was from as well. Coming to the treatment, in non-insertional tendinopathy, most of the patients, like plantar fasciitis, will do well with non-operative management, that is physiotherapy. So that's how people have a major role in treating such patients. So initially there are a lot of this stretching patients. And apart from that, eccentric training is the one which has got a strong evidence, and there are a lot of level of evidence to prove that this eccentric training exercises for the Achilles tendon does well for such patients. Next is your ESWG. Apart from that, we have some pharmacological treatment. Of course, in the long-standing problem, when your physiotherapy exercises doesn't help, we think of giving some injections. Again, steroid injections were given in the past, but it is not recommended now because it causes rupture. PRP, again, like plantar fasciitis, we have a whole here also. Can you see? Healing the pathology. Of course, there are a lot of sclerosing agents, iodine injections, autologous blood injections also being tried, which I got a good result. So surgical treatment. As an orthopedic surgeon, we should decide when to operate. Again, when the treatment, all the non-operative management fails to reduce the symptoms and signs, that is the point where we decide of operating. So, what is the principle of operating? They have to remove the diseased portion of the tendon. So, this is how it looks. It's called a classical crab-meat appearance of the Achilles tendon. There's a degeneration. There's another one. You open, usually this is the open technique. Of course, there are a lot of other techniques by many open. We open, debride, and repair. If the ligament is more than 50% intact, or sorry, the tendon is more than 50% intact, we usually don't repair, we do a regularization procedure. If more than 50% tendon has gone or degenerated, so we have to augment it with some other tendon. Usually we are efficient. So you want to the next topic is the insertion Achilles tendinopathy. So here common risk factor is obesity again, temperature, and other metabolic disorders like diabetes and hypertension, which causes degeneration at the insertion site. And most important is the haggling deformity. So what about the term called haggling? What is this haggling? This is the haggling deformity, which is an enlarged or a prominent superior lateral ganglion neurosity. So this is like a bump. So what happens? Your Achilles tendon gets inserted here, which is under constant pressure or stress by this bump. So that's the common association we see in insertion Achilles tendon. So again, come to the symptoms, they always present with pain, stiffness, and swelling. So this is how it looks. You can see that bump. Okay. And of course, on examination for Achilles tendon type, that's the X-ray. You can see it's a large, huge calcification that happen at the insertion site. And actually, why this calcification happens? This is actually a protective mechanism. Because of the Achilles tendon undergoes stress and strain, it undergoes degeneration. It undergoes something called enchondral ossification, that is cartilage formation, so that it increases the surface area. Surface area, it's an adaptive process for performing well, but unfortunately, that leads to a lot of problems in the future leading to brain. So MRI has a definitive role in evaluating such patients because planning. So with the MRI we can grade and also we can predict the outcomes. Like for example, so grade 1 when you decide when the AB diameter of the tendon is 6 to 8 millimeter and there is non-uniform pattern of degeneration. So it has been documented that 13% of people who are in grade 1 require surgery. Grade 2 when there is more than 8 millimeter diameter and less than 50% ununiform degeneration. And 70% of such patients will go for surgery. Grade 3 is when more than 50% of the tendon has been involved. And here the number 91% of such patients will require surgical treatment. So that's the difference between non-insertional and insertional. As I said, non-insertional majority goes of non-operative management, whereas in insertional, most of them require surgical treatment. And what surgery we do? What's that? Surgery we do debride, like open, debride the tendon, and excise the hanging stump. Once you excise the debride the tendon, you should always repair the implant, otherwise you won't have good function. We try non-operative treatment even if insertional, but majority we go for surgical. Non-operative, again, the eccentric exercises and elasticity has got a good recommendation compared to other methods like injections, PRP, and all your shoe modifications and anesthetics. Surgery, as I said, it's open debride and decompression. This is one of the patients who I operated. So this is the hanging stump fixing, and this is the bilateral problem actually on both sides. So that's how it looks when it's open. This is the degenerated tendon which has been debrided, and this is the bump. You can see it's a cartilage structure just grown, and that's how we the bump its size. Okay. So after debridement and excision of the bump, this is how it looks. And here it's a suture anchor, and you get the tendon back to its insertion. And that's how the X-ray looks here. You can see that previous bump has gone, it has been shaved off, and this is suture anchor which helps in attaching the tendon back to its insertion. This is a functional movement at 10 of 6 weeks, it's the plantar flexion, and that's the dorsiflexion there. And you see the bump has gone. So next problem with acute is acute rupture. So usually we see most commonly sports people, high contact sports persons especially, and also those who have appendicitis factors like tendinosis, previous history of injection of steroids into the tendon, or history of fluoroquinolones. Usually this happens normally in children. Fluoroquinolones is antibiotic which was used, even now they use commonly. But if you use this antibiotic for a long time, it is known to cause degeneration of the tendon and rupture. So what we do in acute rupture, whenever we see a patient coming acute rupture of the tendon, always continuity management is the one which we do commonly, and that's how we follow a protocol which has been adopted from the Swansea Morrison treatment regime. So what we do here is we immobilize the ankle in equinus position with the plaster for 2 weeks. Then after 2 weeks, remove the plaster and then put him on a walker, pneumatic walker with a gradual dorsiflexion, sequential dorsiflexion of the ankle. So such usually they do well with this kind of non-operative treatment. injury is closed. It's not an open injury, and the gap is less than 1 centimeter. You can see a gap. When you examine an acute rupture, when you palpate along the course of the Achilles tendon, you can see a classical gap between the two edges. So, when we do surgery, as I said, less than 1 centimeter, you can always try surgery. So, the gap is more than 1 centimeter. Or if it is an open injury, then there is a cut in the skin exposing the tendon. We have to repair the wound. So, thereby we repair the tendon as well. That's an indication. And whenever there is degeneration, of course, always think of open repair. Coming to the chronic rupture. Chronic rupture happens in especially old people due to degeneration, or sometimes the acute rupture which has not been treated properly or neglected. Even these patients come with problem of chronic degeneration rupture of the Achilles tendon. So what we do here, of course, in any chronic rupture, the answer is always surgical. There is no law of conservative management. We have to otherwise function will be impaired. So there are many techniques. One is DY advancement flaps. So this is the chronic rupture. These are what we see is actually they're not the proper tendon. It's a degenerated tendon trying to heal, but it is not a normal structure. So all these things gets removed by debridement. And this is the VY plastic. We use the gastrofascia or Zoe's fascia in any fashion and pull it down and repair. So the V becomes white. Right? That's why it's called plastic. Secondly is gastrofascia turned down. We turn down the gastrofascia and pull it down and switch it into the distal pattern of the tendon. And the most commonest and the popular surgery is transferring the tendon. We have to transfer to take away the function of Achilles tendon. And here, FHL is the common tendon we harvest and use to reinforce the Achilles tendon because it is enabling structure, it's an agonistic muscle, and easily can be harvested. It's not. So this is the function of the surgical HC, active reflex. So this is the initial technique. We can palpate a gap in the Achilles tendon area. And this is how you look when you open. And this is the aperture. The flexor is longest tendon, which is isolated, and it gets released at the distal end of its course along the talus, and then gets prepared with the suture material. Proper sizing to be done for to use the screw. And this is how it is getting attached to the galvanium. And this is the tenodesis screw to anchor the tendon to the bone. So we move on to the fourth common problem, flat or pesticides. Again, this is common problem, especially in children. You might have seen it. Of course, you might have seen on your own feet. How many of you are flat foot? Yeah. See, there are so many people here in the hall. So again, so it's a common problem, foot and ankle problem. That's why I decided to throw some light on this as well. So what is pesticides or fracture? It's called the progressive collapse of the medial longitudinal arch. Why does it happen? Because of any conditions which disturbs the normal dynamic and static stabilizers of the arch. We all know medial longitudinal arch. I won't go in depth into the anatomy. It is mainly maintained by both soft tissue and bony structure. Again, in soft tissue, we have a lot of ligaments, out of which the plantar fascia has significant role, and muscles, out of which tibial supported tendon does play a major role in maintaining the arch. So, pesticides can be congenital or acquired. Congenital, there are other conditions like congenital vertical talus, presence of coalition, excessive angular force. These are all neuromuscular problems which will lead to deformity, which is present since birth. Whereas acquired deformity is the one which happens at the later stages of life. And out of which I have highlighted this PTTD is what posterior tibial tendon deficiency, which I will be concentrating more in my talk today. Followed by midfoot arthritis or any traumatic situations, sharp toe, diabetic sharp toe, and hyperkinetic syndrome. All these can lead to acquired fracture deformity. So coming to the fracture in children, as I said, it's very common. Up to 2 years of age, 90% of children will have fracture. So when they grow up between 5 to 6 years, that incidence comes down. You can see only 50% of this age group children have fracture. And as they even grow older, you can see the incidence drops down to 4%. So I want to stress here that this is the normal phenomenon which happens. It's called physiological fracture. So every individual, when we born, we have fracture, and as they grow, they develop the arch. And most of these children with the flat foot are asymptomatic. And always we see in my clinic or in our clinic, especially I see many people only but it's a parental concern. Usually the parents get their children, they will be anxious, thinking that, oh, my child has got some problem, therefore feeling something. But absolutely there will be nothing and no problem at all with the children. They have flat. Anyone can tell me who is the world's fastest runner? Usain Bolt. Usain Bolt has got flat, and still he is the fastest runner in the world. So remember. So but however, some children do come with some problem, especially around 9 to 10 years. What problem they usually have until pain when they do a lot of exercises, activities in school. Again, here we always do conservative management with orthopedic supported exercises. And if there is actually any deformity like congenital vertical talus is the only of surgical. So coming to flat footing adults, as I told, PTD is the commonest cause, and that's the telescopic tendon. Here we should remember that there is a microvascular area 4 cm above the incision. It's inserted to the navicular and just 4 cm above. There is a relatively microvascular zone for 14 millimeter, and that's the area which undergoes degeneration frequently and rupture. So this tendon, as I said, it's the main dynamic stabilizer for the arch. When this function is gone, the arch collapses. So how do they present? They come with pain, swelling, especially on the middle aspect of the ankle, difficulty in walk, hard to take pattern, and the clinical examination you have valgus deformity. This is how normally you can pass 2 fingers or 1 finger under the arch up to the proximal joint. However, in case of collapsed arch, it is not possible. Then next step is we should check whether the deformity is flexible or not. And the easiest and commonest test performed is a Jack's test or heel raise or toe of tiptoe stance raise. When you dorsiflex the radioactive MTP joint, you can see the arch appears. So this is in a normal stance raise. When you dorsiflex without the arch, this indicates that the deformity is dynamic or flexible. It's not a rigid. Why this happens? This happens because of the plantar fascia through the mechanism called whiplash mechanism. Again, when you see, you can see this is the extreme, the heel has marked for extreme valgus, and so too many toe signs. You can see all 3 or the last 4 toes. When you look from the back, normally it's not visible when you look from the back. And the foot goes for abduction, and 4 foot goes for supination. This is called heel raise test. This is double heel raise. Also, we should do a single heel raise as well. So you can see once the heel goes up, the valgus deformity is corrected. It is going into balance. This is the normal phenomenon which should happen. So again, this indicates deformity is flexible. However, here, even after heel raising, the heel is still in balance. Never forget our silver square test again here. So So reverse characters that got following almost all good and conditions. Always think. What is significance? The tight gastric muscle. Majority of these flat patients will have tight gastro. We can score, especially when you see flat foot in young patients, evaluate with hyperglycemic syndrome. Anything more than 4 is a significant. And what are the indications for your treatment? When you consider treatment, any flat foot patients come with pain, deformity, and difficulty in walking. And what are our goals of treatment? It's not only to get away with the pain, we should always restore the function completely. And most important is you have to prevent the progression of the deformity. Remember, I told the definition, it is a progressive collapsing deformity. So your treatment should take this into consideration to prevent the progression. So always first kind of management is non-operative. Yes. So before that we do staging. There is a separate classification I am not covering because it takes a lot of time. The staging is done by Johnson and Strauss. It's divided into 4 stages. So in all the stages, always try to get in non-operative management first, but more effective in stage 1 and stage 2. So for acute pain, really NSAID is physical therapy by using therapy, strengthening exercises for the posterior tibial tendons, device position and gastro stretching exercises. We give a short duration of immobilization by using a walker or a plaster. Corticosteroid is injected only if you suspect any arthritic joints or inflammatory pathogens. Orthosis is the main role. Apart from the physical therapy, orthosis plays a significant role. It not only corrects the deformity, it also offloads the injured structures. How do we do this? There are various kinds of orthosis. It's called a semi-rigid orthosis, which has got so many modifications, which actually corrects the fracture deformity and it maintains the proper shape. This is one of the most popular orthosis is by University of California Laboratories, especially in stage 2 disease. So stage 1 is when actually there is no deformity. Patients come with only pain and swelling. So it's a stage of ending of the device position has got into inflammation. Stage 2 is one when we see deformity, but it will be flexible. Okay. Again, here we use this kind of orthosis. So when do we consider surgical treatment? Whenever all our conservative management has failed to get away with the pain and prevent progression, think of surgical treatment. Again, depends on age of the patient, stage of the deformity, and activity level, presence or absence of arthritis. So in stage 1, as I said, it's an inflammatory stage where we do only lesion debridement. Otherwise, nowadays it is not so popular because just doing debridement will not get rid of the problem. We do always combine process along with bone osteopathy. So what we do here is we shift the calculation. As I said, in test planes, what happens? The heat goes into valgus. So here, this is the view where you can see the heat going to valgus. So we do the offsetting of the calculation and shift the calculation onto the medial side. It's called medial shifting or medial calculation offsetting. So in stage A and B, flexible deformities, we do a procedure called orthoeresis. Orthoeresis means it is stabilization of the subtalar joint by extra-articular orthosis. And EOTTs is one of the methods. It's called extra-osseous tap-out-axis stabilization. I just show an example here. 18-year-old boy, he came to me with pain, with flexible deformity. This was the deformity you can see in valgus. This is the heel bracing test. He was able to perform double heel legs. That means the device position tendon is still working. And this is actually, you can see the talus is almost facing down. So completely collapsed down. There is no arch visible. Always you take weight bearing X-ray. Take a non-weight bearing X-ray. So I did a calculation after that. This is the shifting. The bone has been cut and shifted clearly, which is the screw. And this is the pivot case procedure where we introduce an implant. It's called cytostasis implant. Use the talus. In the previous X-ray, you could see the talus was collapsed. Now it is lifted up. So that previously the yield was in extreme values, now it is almost the near normal position. We can see arch here. Previously it was complete, the midfoot was touching the ground. And thus the heel rise still is able to perform. Heel rise. This is another particular wall with flexible platform deformity. We see extreme values on both sides. This is the next way. In I did calculating mastectomy and sinus implant. Correct deformity. So operated only on the left side. If you still view on the right side, is get corrected. So there is another question called lateral calculating mastectomy or called lateral column lengthening. When you consider when the midfoot has gone for extreme abduction, to correct that, we have to do an osteotomy at the calcaneum and place a wedge for open wedge osteotomy and lengthen the lateral part of the foot. So the abduction gets corrected and the foot goes inward. Freeform osteotomy is the middle freeform again is the open wedge osteotomy. When do we do? When the patient has got deformity along with the forefoot supination and trans. Tendon transfer we do when the tibialis posterior tendon function has been impaired. So we have to reinforce with some other structure. Here we use FHL or FDL. FDL is the common tendon transfer we do. So the FDL is harvested and attached to the navicular mode. One of my patients which I did, that's the FDL, flexor deltoid longus tendon harvested. We cut just above the muscle part of the knee and gets attached to the navicular mode. Right. So that takes away the function of weak tibialis posterior tendon. Apart from that, we FHL transfer also, but of course this has got a lot of complications, so it has not become much popular. FDL is the one we always prefer. There are other transfers like Veronese breathing to FDL transfer. Stage 3. The subtalar joint becomes fixed. You won't get any flexibility. Why does it happen? Because of two conditions. One is tarsal coalition. What is coalition? As I said before, it is a abnormal bridge or a bony or fibrous connection between the tarsal bones. Second common condition is arthritis. If long-standing test deformity lead to arthritis of the subtalar. This is called rigid deformity or stage 3. Here again the plan of treatment differs. You always consider fusion. An example, taking about man, you can see this is the coalition, actually the coalition. You can see there is a bridge between talus and the calcaneum. There is no space, there is no subtalar joint. And also there is no space between the cuboid and the calcaneum. It's called two coalitions. That's the bony bridge we see. And we need a double fusion. Double fusion is using the subtalar as well as talar joint so that the arch is also corrected and we take away the strain. That's the post-op picture. Where we see double fusion. So that's the subtalar joint and the talar joint has been fused. Correct deformity as well as this is on the left foot we have operated. You can see the arch restored. Okay. The DPC only came through. The first video this is the last picture here. This one there is the just click there.
Go ahead.
Click it. Yeah, I think I'm taking a lot of time, as I said beginning of my speech, because it takes an entire day for me to cover all internet problems. And anyway, and I'll try to finish off early. I'll take another just 5 more minutes and just rush through. Just, thanks. This another patient who came with. This was a communication which she has also got Alex Varus along with the Blackwood. That's how they were looking and that's the correction. And that's also the address. And the Blackwood was corrected because it was rigid and it double fusion. That's how post op you see the intro now looking straight. That's the arch restored. If you have a lot of other procedures, of course, don't forget about gastro tightness and it is so released. And stage 4 is called involvement of the ankle joint where we use the ankle joint. The last common condition as well as the diabetic sharp. Of course, I know you have got a big session on diabetic sharp in the subsequent talk. I won't go into detail, just in the management. So before that, evaluation is most important. So look for the bony prominences, any ulcers. Also look for proprioception and vibration in the cover. Of course, don't forget the vascularity. Here, you always do AGI, it's called ankle Baker index. The normal is between 0.9 to 1.4. Any deviation less than 0.7 is significant. So, investigation to note any infection associated blood sugar, out of which HbA1c plays the main role in modality. Of course, to confirm the vascularity to arterial Doppler. So, early treatment in diabetic Charcot, we go with non-invasive total. This is called total contact cast, where we protect all the bony prominences and the ulcers. This has got a very beautiful role in management, especially the early. See, the basic principle in managing diabetic Charcot is you should prevent the progression of the deformity, prevent ulcerations and complications. Okay, so to do that, these are the modalities. So we give a total contact cast, we can give a rigid AFO, or it's called pro boot. It's called Charcot resistant orthotic walker. So pro boot again, it has got a beautiful role to offload the injured structures. This is 4-foot offloading. You see, only the weight takes only on the knee. The 4-foot is free. So any lesions in the 4-foot get straight up when you use this kind of tool. So indication for surgery, when we consider surgery diabetic Charcot, when there is non-healing ulcer with the bony prominences, always surgical treatment. It never gets to be whatever treatment constitution. And if there is infection, we have to do surgery. And if the foot is unstable and we can't give any brace, that's the time we always think of surgical treatment. And the principle is to correct the deformity and prevent the progression. Always the surgery is done in stage 2 and stage 3. We got different stages, but I'm not going to touch those aspects. So this was a stage 3 consolidation already happened. You can see this is a midfoot collapse. You can see this bony prominences and this predisposed to an ulcer here. That's how the diabetic patients develop an ulcer. So we do exhaustively where we do the abnormal bony prominences. This is how we open and take away the bony bump. We use it and stabilize the midfoot by using the screw. This is how the midfoot now. So the bump, whatever it was here, it has been taken off and the arch is restored. And this helps in healing the ulcer. So that's the post-op. That's that's how it looks very deep. And that's how it's really play. That's how the dynamic patient walking after surgery. Standards and activation is very important. Older days, activation was commonly performed raw diaphragm, but it's really the mortality rate after amputation is huge. The 5 year survivability after an amputation in diabetics very survivability is very less. So always think of salvation. But sometimes there are certain conditions when things goes out of our way, like when the blood sugar is uncontrolled, HbA1c more than 9, vascularity is very poor, the antibiotic is less than 0.7, and uncontrollable infection or multiple ulcers. You can't do salvage or this for amputation. So these are some of the examples which we have taken. The ankle is unstable, you can see. Hardly there is any ankle joint there. The foot was highly unstable. So we need to give some stable foot, otherwise you can't walk. So that's called hindfoot shadow, involving the hindfoot joint. Stabilize that, we use the hindfoot tape. So after using it's for TTC fusion, the ankle gets stabilized. Once it heals after 6 months, we make it walk. So this is after healing, you can see completely fused and the joint has been stable. That's how they look. This is another case, you can see deformity here. This is the bony problem. The tibia is actually touching the ground. That's how they can see this. Classical picture we see X-ray diabetic sarcoma is destruction. And this is the weak foot arthritis. Sorry, this is the infection. Now, initially I did fixator to control the infection. This is called visa or fixator to control the infection. Once the infection is controlled, then we do stabilization by using the complete mission achieved. The case with ulcer. So this actually interesting case. She had gone to 3 or 4 surgeons. Everybody advised amputation. This kind of infection came to me and it was completely infected to bone pus. So again, I did a 2-stage. This was the X-ray. You see completely destroyed joint, subluxated ankle. So I went in divided the way all the infected material and stabilized the fixator initially. So after 6 to 12 weeks, the infection got controlled. This was the picture. Then I did PDC day. And that's how she's now having this way. Take home message always in diabetic sarcoma. Early detection is the most important thing to remember, and appropriate treatment to prevent the deformity as well as complications. So actually the theme of diabetic sarcoma is always save the foot. It is the best foot possible. So with this, I'm going to conclude. I know probably I might have bored you, but that's how my topic was given to me. In fact, it's very easy to stay on one particular subject or one topic, but since I could cover common foot and ankle problems, I hope I have covered most important problems around foot and ankle. And once again, I thank all the organizers for inviting me. It was a great pleasure coming over here.
Dr. Chief Physiotherapist at Vesoma Medical Insurance Center, Sports Excellence, Bangalore, and Dr. Pradeep, Professor and Principal at Verna College for the discussion.
Thank you, Doctor, for a wonderful presentation about ankle foot. You have given a lot of information. As a physio, it is very useful. The reason we have to understand about the way of surgeries. Based on that, we can design our rehabilitation program. So, before asking a dedicated question, so I have one question. As a physio, So we have been seeing lot of athletes having a platform, symptomatic or asymptomatic. So precaution since they have a high activity, so we are advised to go for the customized treatment. So what do you think about your perception? Is it advisable or not?
Food and access surgeon is worried about any or any profession. So if any patient comes to me with a back, but it is absolutely asymptomatic, but not having any problem. Don't think, don't think about it. Not even issues. But however, in case of athletes, because you just stressed upon the point athlete or the professional athletes, so what we can address is very very exposed. Of course, I mean, it needs a lot of evaluation. So first we have to find out the kind of problem is because of what. Whether it is a congenital problem or it is an acquired problem. Usually acquired problem does have some problem. They come with some they come with some pains, some pains. This congenital doesn't have without any polish, there will be absolutely no way. In such patients, what we can evaluate the different exposure strength and teach them strengthening experience, strengthening. That would be more than sufficient for asymptomatic. Yeah. Rather than because if you give and it's so because in such patients, a sports person who has a bad foot, his foot has been already adjusted that it's performing well. As I said, the same foot is a fastest man. So if it adjusted that performing well, so if you try to correct the arch by giving some insole arch, actually it was more problem than anything else. That's why in asymptomatic, we never advise any treatment modalities. The utmost thing we can advise is strengthening of the device system. That's it.
Thank you. Thank you. Just one more question, Dr. Sorry.
Sure.
So we are dealing with athletes age between 12 to 25. So for recurrent injuries, tendinitis or something, is advised to go for a PRP or corticosteroid?
For athletes,
For athletes,
depending on again the clinical evaluation. If mild to moderate symptoms and your power is good, like patient and performance is good, but still the patient has got some pain. You're talking about non-insertion or insertion? Yeah. Insertional initially always first 3 to 6 months of time we can try all modalities of non-operative management, starting from physical therapy, physio exercises, and injections. Injection I would prefer VRP rather than steroid. Steroids definitely will cause problem, leads to rupture.
Thank you.
So I would have one question regarding the research part. To access physios, we have to concentrate on any particular field.
I see the reason why we do this topic is because if you observe my presentation, most of my all the foot and ankle problems have got some role of it. Because some has major role, especially when you go for non-operative management. So definitely there is a really good scope, especially for the students. You can do a lot of research activities on foot and ankle patients by trying many modalities like ESWT or exercise regime, etc. Of course, there are already studies that have come up in the Western literature, but Indian literature, there are very few studies. All the studies which are quoted, if you had observed, all the literature references were taken from the Western literature. So there are hardly few literature published in Indian countries. So that's the reason I advise the students, you come up with the topics, study on our Indian patients, because each patient differs geographically. So you can do the same study. You might find some difference. You might find different outcome. And that's how we come up with the new technology or innovation.
Definitely. Any questions? Sir? Oliver.
It's a screw. It's not an air port. It's POTS. That's
So,
it.
I was a coach.
Okay.
I want to ask a sports, let's say, question. Now, after the initial stage of the treatment, that patient or any patient, he will be able with that screw to perform some kind of physical activity, or there is a way of removal that after the art has been somehow corrected.
No. The screw, it's actually called not called specific implant.
Okay.
That's the procedure is called orthoeresis. Eresis means we are stabilizing. The purpose of that implant is to not only to lift the arch, but also it stabilizes the subtalar joint. And eventually, what happens is the implant gets incorporated inside. So there will be a lot of fibrosis which undergoes around the implant. It stays there forever. We are not supposed to remove that. And removing it is also very difficult. And there is no reason to remove. And they can do all activities. They can perform all sports activities, routine activities, everything.
Because the first time I saw that.
Yeah, that's a new technology. Recently, it's been popularized. In India, for the past 2 years, we started doing this. Of course, it has come with US and UK market very long time. Thank you. Thank you.
Anyone?
Delegates, if you have any questions, I request you all to please raise your hands. The volunteers will be bringing the mic. Delegates, if you have any questions.
Hello, myself Suraksha. I would like to know post-childhood for management with fusion with respect to physiotherapy perspective. What is our role? Like, there is no much of function we could get into, like dorsiflexion range or anything. Only with respect to weight bearing, or is there anything else? We could
Procedures. And when we do this kind of procedures in diabetic patients, we need to keep a long-term immobilization and keep them long-term non-weight. Whether it's foot or we have to protect it for a very long time, and that duration take up to 6 months. So until 6 months, we will not be able to take weight on the affected leg. So the role of few people comes in training them in non-weight bearing ambulation, either crutches or walker. Okay, so coming to the range of movement or ankle movement, you said movement of the ankle. See, in case of high foot fusion, which I showed some of the examples where I fused the ankle to the knee. So entire high foot is fused. So there is no question of ankle. So there will be no movement at all. The purpose of doing that surgery is to stabilize the ankle. They absolutely don't have any movement ankle. But once the bony happens well, you can allow them to take weight. So obviously, after immobilizing for long term for 6 months, it is difficult for them to take weight. So initially we advise them partial weight for 3 weeks. Then advise full weight. Again, your role comes in the picture where you train them how to take partial weight and how to take full weight. In case of midfoot position, of course, the hindfoot is still free. There you can teach them to do ankle exercises because only the midfoot portion has been used. Ankle is still free to act. Then the ankle movements comes into picture. Thank you.
Thank you, delegates. Any other questions? Okay. I would like to thank Dr. Shekhar for giving us a remarkable presentation on the conditions of foot and ankle and wonderfully explaining each and every procedure. At the same time, I would like to thank the chairperson for today's session, Dr. Balakrishnan and Dr. Pradeep, for wonderfully chairing the session. Now I would request Dr. Balakrishnan and Pradeep to facilitate Dr. Shekhar. Now I would like to request Dr. Vimarsha and Dr. Spooty to felicitate Dr. Rani. Thank you, sir. Now moving on to the second session for today, we have Dr. Pradeep Rai for topic correction of diabetic foot deformities. Sir is presently working as assistant professor in Department of Plastic and Reconstructive Surgery at TE Sangler, and Sir is the director of Ellore Skin and Plastic Surgery Clinic in Bangalore, with over 1,500 surgeries to his credit, including facial fractures, nerve repairs, and diabetic foot reconstruction. He is renowned of his expertise and has published both national and international papers. Please join me to welcome Dr. Pradeep Raj. Now I would like to welcome the chairperson for this session, Dr. Sharada, professor from Acharya College Institute, and Dr. Vasan, professor and principal from Oxford College of Physiotherapy.
Good morning, my lord. Today, I will speak about the principles of diet. As we are more associated with the other, I will be speaking about the humans associated properties and how to treat them through plants and science of the genome. So, to begin with, let's brush through the list of ecological basis. So, for the cause of the deformities. Yeah. Why are we getting diabetes nowadays? Diabetes is the end stage of where diabetes is reached. Actually, it can be cured compared to other diabetic illnesses. Now, the diabetic and anti-deformities you see that are mainly because of the negligence of the patient. The untimely taking the patient to the doctor is the main reason why the patient is diabetic. to treat the diabetic foot, they have to know what is causing that. The main three vicious triad which are causing diabetic foot. One is the infection, one is the neuropathy, and is the plasma. These three, they intermingle, intertwine, and they just the vicious circle which are causing diabetic foot and diabetic foot. One thing they have to do before identify these factors. Now, all the 70% of low limb amputations begin with ulcer. Small ulcer, which are detected thinking that they can be cured on their own. No. Once you address this ulcer, it's possible that you can take 70%, you can save 70% of the diabetic foot.
Wait, wait.
Sorry for the inconvenience. We have a technical issue.
Now let's go to the neuropathy, the basic cause of protein. One, there are three aspects in the neuropathy. One is motor neuropathy, sensory, autonomic. All those various types of neuropathy and same difference. Okay, now let's go to the motor. What is motor neuropathy? The intrinsic muscles which supply the food and hold the metatarsus together and help in motion is affected. They go into atrophy because of neuropathy as well as neuropathy. When they go to neuropathy, there is loss of stability of the metatarsus and hence there are different pressure points causes ulcers, and also there is deformities that are responsible for the brushing marks. Now let's go to the sensory aspect. Loss of sensation, again the protective sensation is lost, and hence the patient will have the recurrent ulcers and multiple injuries without notice. Now the autonomic. The autonomic is there is the altered blood supply to the skin and there is a reduced moisture, increased dryness, visual and infection are common. Now, dietary food. Now let's go to the abnormality caused in joints. Why is it abnormality in joints? In diabetics, with uncontrolled diabetes blood sugar, there will be non-enzymatic glycation and advanced glycation products into the tendons. It is deposits all over the tendons, soft tissues, and what these causes? This will cause stiffness and rigidity of the tendons and bones. Hence, there will be limited joint mobility. When there is limited joint mobility, the force, the parallel force acting on the foot will increase. When the parallel force increases on the foot, it causes ulceration or wound. When wound occurs, there will be velocity around the foot. It is a protective mechanism of the skin to form velocities around the articulation. Now, because subcutaneous will have ulcers, the ulcers get infected because diabetes are prone to infection, uncontrolled blood sugars. Now, localized access and possibilities in the tissue. And then there will be other infection along the tendon planes. There will be necrosis, sloughing, and loss of structure, causes wound and deformity. Now, what are the main deformities or common deformities in diabetes? One of the most common, that is 60% of the foot deformities are prominent metastases. This is very common foot problem we see in diabetes. Another one is wasting of intrinsics. When the intrinsics are wasted, there will be flat foots, which causes ulcers at the edge of the metatarsus. Next one is hammer toe of the alex. Even the smaller toe can also get alex deformities. The other is stress cables, elevated arms of the foot. Elevated arms of the foot also disadvantages. I tell you further. Other deformities, chloro. Now, see, once the deformity occurs, these are the pressure points which occur and cause ulceration of the foot. These are the highest zones for ulceration. The prominent metatarsal will cause ulceration of the head of the metatarsals, and hamatoes, chlorotoes will cause ulceration of the great toe, distal aspect, and sarcos may cause midfoot subluxation and cause ulceration and wound for the midfoot, and calcaneal abnormalities or subluxation can cause wound of the knee. That is the IR foot with hamatoe deformity. This is the sarcos midfoot, and this is alex valgus deformity of the infected and deformed foot. So what are the skin changes we see in the diabetic foot? One is commonly dryness, because I told it is autonomous abnormality. Autonomous abnormality of the sensor nerve will cause dryness of the skin, which will lead to fissures in the skin. Fissures are based in the skin. Again, the fissures will cause calluses, and the calluses may also entertain the infection, that is fungal infections, and which will lead to foot ulcers. There will be brittle nails due to loss of blood supply as neuropathy, and ultimately they will go into osteomyelitis and sinus formation. Now, you can see the ulcer wound here. You can see the deformity of the toe and the midfoot. The tendons were exposed in the midfoot, and the bone was exposed and rotated in the distal aspect of the hands. So first what we have to do in these cases is first we have to control the infection. How to put in contact with the floor.
Where to position this now? We'll have to position it where.
This again result also.
Camera is gone. It's not working. We have to connect the webcam.
This is the ulceration prominence. You can again wide hypertrophic ulceration of the metatarsal with hyperprominent.
They've gone to handle cult people.
Now,
Can you keep it here?
prominent metatarsal with classes and they were and then realignment of the vessel to balance the output and the flow. And then we cover the wound with the liver plastic. When you see the black mark there, it is a heat flag, and this is how it looks after the correction. After the correction, now we gave us the interesting mind for the develop, gave us a and associate time plan with the
Seat and liquor problem.
camera ಮೇಲೆ. Now see this. Again, for the personal planning to have or high pressure over the personal planning to have. What we do is we can do a pressure anatomy in these cases to release the flexion deformity. It might be minimally invasive or open surgery, and once you release the tendon and you take over the liver plastic or the rotation plan, this is how it looks after 6 months. This is also again a huge plan. So main correction how we this is another now for single invasive, there's optimal concept where you go minimally with a sharp knife and make a step ladder position, or you just partial tendon so that anatomy across and there is release of the deformity.
Switch off the video.
Flexible deformities. In the rigid deformities, tendon realignment or tendon deformity. The osteogenesis is that is osteotomy
This is
and
in between.
osteotomy is where rigid contractures are present in the GI joints that help in rigid deformities. Now let's go to lesser metatarsals. Lesser metatarsals and the major metatarsals. Lesser metatarsal one thing improved. The starting second
Yeah.
metatarsals.
But it won't sit
These
still.
metatarsals, if anyone is gone, all the other two will subject further will cause
We'll have to keep it here.
other toes. So once if you are treating the lesser metatarsal, treat them all together. Third, second, third, and fourth metatarsal. This is the lesson metatarsal treated with liver plastic with correction of the lesser metatarsal with that's a release as well as osteoclasts. Osteoclasts is nothing but osteotomy. This is the type of the lesser metatarsal. Now this again another wide involving second to fourth toe prominent bits of the metatarsal. It is a single unit and hence if one unit gets infected, all other units also going for preservation. This is flat metatarsals with osteoclasts. So the now normal parabola. What is normal parabola? The second, third, fourth function is single unit. So it forms a normal parabola, normal arc. If any one of the arc is lost, any one function is lost, the whole of the arc is lost, and then further mixture with the formation and deformation. So you have to treat them in one group. exposed wounds. So this condition, you have to remove all the exosurface, exospectrum which are, and then remove of the necrosis, necrotic tissue, pressure tightness, occupy the wound, occupy the infection, and then put the plaque over and save the. This again, 4-foot ulceration, exposed bone, necrotic pneumonitis, have to treat bone, soft tissue altogether. We have to excite the osmotic segment, save the metatarsal. Metatarsal is still there, and we do the task so that the arc is weakened and patient can balance the weight. Now this is the 8-year-old female with recurrent ulceration on the foot. She has good good variation for good glycemic control. But the problem is she is a comorbid. She has a ischemic heart disease also. We cannot go for a major procedure. So we plan for grafting and external operating. And this is how it works. After grafting and external operating. Killer abdominoplasty, really done, but it can be done in very rigid properties, and patient who is older enough, so that the main state has a status. Main state is highly rigid and patient has 0 to 30 degree of dorsal flexion of the toe, and in that cases patient can go for killer abdominoplasty. Because a gap or abdominoplasty interposition with patient and the or gap abdominoplasty with care of physician. But joint stability is a major complication. Killer abdominoplasty to give a proper external. Now, lastly, we can see Chalmers osteoarthropathy. Which is a major problem, but luckily it is only 1 to 2% in that. Not much of them would Chalmers, because before that they may have other problems and they may many surgical techniques have been described to treat the orthopods, but simple plantar exospectomy as already told, without device antibiotemy, midfoot realignment orthosis as already covered by the operation, will fix the midfoot and ankle orthosis also can be done in axial extremities and ankle orthosis. The combination of procedures most often required for Charcot deformity are multi-level. You cannot treat one segment and leave the other segment. Keep the other segment for the depth. Now, all the orthotics using instructions most often practiced everywhere. Multicolor external circular fixation. These are techniques are used. Therefore, usually multicolor 1 or 2 or other 2 to 4 can be used to save the lift, because it is not usual in the that you have a normal. It goes into various stages. Charcoal go into 4 stages. One is simple inflammation in the beginning. Then it goes for a fragmentation where all the ones are lost. Don't ever stop at all. Fragmentation is there, and then they go start coalescing on the string. Once they start bridging and coalesce, then there is a separation where that time they fix the mixing. See, the platform with which could do subluxation with wounds, fissures. This is how the chapter. Can you see any bone on the foot? There is no ankle joint. There is no metatarsals, no tarsus. There is a fragmentation period. This is the inflammatory fragmentation period. We have to treat this with antibiotics and cross-sectional orthotics, and then once there is consolidation, we can treat the patient with fixation. This again ankle osteomyelitis with Charcot and flap for them. Flap gives a vascular grip to the bone as well as the joint. And once this is done, the inflammation and the infection comes out. But still, once Charcot it never comes down. You have to take the Charcot. This again will put IR Charcot foot. You can see the deformities from the standard with foot ulceration. We just control the infection and the graft transmission. All patient not be fixation, but still now we use renal fixation in psoriasis period. But if at all the patient needs an earlier period, psoriasis can be used. But bipolar illness to establish a stable pathway for mitigating the focal areas of infused and stable internal treating as well as external treating and both hand in hand in treating diabetes.
And Dr. Vasan, Professor and Principal, Oxford College of Physiotherapy, and Dr. Sharda, Professor from Acharya College of Physiotherapy, to give their valuable points on this session.
Participation was really aesthetic, but that's the sad part of the complete that being see so many people in so much of suffering. So why is the problem so severe? Why do people reach for the past? What can be done in order to get in people so that they don't get into such problems at a young stage?
Major problems because they are timely interventions, not they don't need proper point of time. Because even the telephone is they carry the technique. They want to they have to deal with that. Or something is bothering them. And if they bother them, and sometimes they don't handle it even that way, you know. So both these the patients and they come out most like
In your practice, what is the rate of recurrence, not of just the surgery part of it, which you are redoing it, but in terms of since their ability to get the feet is less. So, even after surgery, you feel that people to continue with the same problem over and over.
and follow. After 1 2 years, these 2 years we can with our components and after 2 years later, the patient is referred with the follow or patient does not take care of the test. But if the patient was sent for and follow,
Phonics and shadow. And my subject is coming. I would rather like to have a lecture more focused on than analytical and surgical paper. So my first question to you would be, how often is food screen in the clinical? Because we have many diabetic doctors, and this is why I have a question. If we have so many diabetic doctors, why do our patients end up with surgery?
probably that will be only the next that problems be there, that will be and this will be there, but it's normally all this and take care of like I said,
question to you as a surgeon. What would be your recommendation? At what age should it be mandated that people screen to be checked for any preventable systems?
Patient is diagnosed for
I'm not speaking only about patient, I'm speaking even about the risk population or what would be your suggestion for mandating
diagnosis for the patient is not doesn't have any complications, then go for the patient is identified. Out of 6 months, patient is having more and even ulceration and complications, then you have to perform 1 or 2 months.
we have seen that there is vascular fatigue or definite neuropathy, which is also present. How well are the graphs taken? What has been your experience?
Actually, other laws of labs that they most of the diagnostics are actually and I think one spite of that labs and labs are very well. One thing I have to do is the point and once you are that's much because the politics they pay the part.
And very about that was because this will help us to space the physical examination. If ever we can give of any assistance during this phase.
Yes.
So this was for the younger generation that I have participation. Sir has already asked you about the earliest diabetic food that you see as a surgeon. As per what you had said, that the last one of the elective ones. And with the majority of the food, like around 40-60% in the profile acting food that was summarize. I would like to ask you, what is that missing component of awareness that you have faced as a surgeon when it comes to the Indian diabetic population?
We are not probably class and make them aware that this is going on in case in the so it's not good patient not go on most patients very less but they know the food life and so education is very good and preventing the major once patient is educated you think the economy patient at most direction and follows up and takes good care of the further economies and prevents conservation and
So, with regard to prevention and management of the
management will well support was exercises of the mobilization and then fitness and offered very important big like big we define offering and even the exercise for
Any questions from the audience?
I hope so. There is no question from the audience. There question.
Sir, anything which can tell us that the role of physiotherapy before the chronic stage of neuropathy can reduce the severity of neuropathy? Glycemic, with physical activities.
physical activity that is what we have to control the pressure points. Because of the glycemic, the more glycemic index, there will be, as I showed, glycation of the venous. Where because of that glycation, there is competition of the venous. And absolutely,
And increasing the physical activity, that is again awareness, because it again reduces the glycemic control with the comorbidities like low exercise.
Thank you. Do we have any other delegates? Anyone who wants to ask a question can raise their hands. Okay. I would like to thank Dr. Pradeep Raj sir for giving an insight on diabetic foot in a beautiful manner. And especially I would like to thank the chairpersons for the event today, Dr. Vasant and Dr. Sudati ma'am, for beautifully putting their points in the discussion and adding up to the questions, which actually deepen our insight on the following topic. Now I would request ma'am and sir to please felicitate Dr. Pradeep Raj. Thank you, Pradeep sir. Now I would request Dr. Shrubina, Associate Professor from Prudence College of Physiotherapy, and Dr. Janaki from College of Physiotherapy, Dayanasara University, to felicitate the chairpersons for today. Thank you, sir. Thank you, ma'am. Thank you all delegates for all your kind cooperation. Now I request you all to proceed for a tea break, which will be for 10 minutes. You all can go downstairs and at the corridor you can see the tea being served. I request you all to please move for a tea break. And right after 10 minutes, I request you all to occupy your seats as we will be starting with our inaugural function.
ರೋಹಿತ್ ಕ್ಯಾಮ್ರಾ ಬರ್ತದೆ ವೆಬ್ ಕ್ಯಾಮ್ರಾ ಹಾ
that promises to be both enlightening and inspiring. The highlights of the symposium include hands-on workshop, plenary sessions, and innovative talks. I encourage you all to actively participate and engage with the speakers and the fellow attendees. To set the stage for the symposium and to celebrate the spirit of a theme from soul to soul, taking a step towards a better health, we have a special performance prepared for you. This welcome dance symbolizes the harmony of movement and wellness, reflecting the essence of our gathering. It is my pleasure to call upon Ms. Harini from CPAT to present this captivating welcome dance. Please join me in welcoming Ms. Harini to stage. Audience, I request you all to please cooperate for a minute. We have a technical glitch here. Thank you for your cooperation. Now, performance are distinct dignitaries of the for which I request you to please escort the dignitaries of the day. Shashivarnam Thank you, Ms. Nisha, Akshaya, and Ms. Mishan from CP Leaders and Invocation. Lamp lighting. The tradition of lamp lighting holds a significant place in our culture, symbolizing the discipline of darkness and the ushering of knowledge and wisdom. As we light the lamp, we invoke the divine blessings to guide us in her endeavors and illuminate our path with clarity and insight. I would like to invite our esteemed dignitaries on stage for the ceremonial lamp lighting. Thank you, dignitaries on the days and off the days. Let this act of life symbolizes the beginning of a fruitful and enlightening symposium. Now, I would like to call upon Professor Dr. Satyaguru Prasad, College of Physiotherapy, Ramansagar University, and the organizing chairman of the event to address the gathering.
Thank you so much, Dr. Prasad. Ladies and gentlemen, distinguished guests, esteemed speakers, and my dear students, a very good morning to one and all. It is my privilege to welcome you all to our TSU National Symposium 2024 with a theme From Soul to Soul, Taking a Step Towards Better Care, a journey through the limb of podiatry. Today, we gather to explore the intricacies of human foot and its profound impact on our overall well-being. As physiotherapists, we understand the vital role the podiatry plays in maintaining optimal care. Our foot are the bridge between our body and the ground, yet they are often overlooked until pain or dysfunction arises. This symposium is a tribute to our commitment in advancing the field of podiatry and enhancing patient care. We have gathered renowned experts to share their knowledge, experience, and innovative approaches to address various aspects of podiatry. Throughout the symposium, we will explore the latest research techniques and best practice in podiatry. Let us embrace this opportunity to learn from each other and inspire new ideas. Together, we can make a meaningful difference in the lives of the patients whom we treat every day. I would like to put a note over here of how many colleges and how many abstracts we have got. In this TSU National Symposium, we have got more than 150 registrations from across India, like Delhi, Rajasthan, Maharashtra, Gujarat, Andhra Pradesh, Tamil Nadu, Kerala, and Karnataka. We have got more than 64 research papers presentation, which includes PhD, PG, UG, academician, clinician category. We have 6 plenary sessions. Yesterday we have done with 2 and today we have 4, and we have 8 innovative talks from different people. Thank you for joining in this journey from soul to soul. Now, I would like to take this opportunity to welcome our chief guest, Mr. Petros, Managing Director, Bangalore International Football Academy, UEFAB license holder, coach for Greek national men's soccer team, currently associated with Dravid Patron Sports Academy. Put your hands to welcome our chief guest, Mr. Petros. I'd like to call Sri Hari Sharma to welcome Mr. Petros. It is my privilege to extend my warm welcome to our guest of honor, Dr. Pushpa Sarkar, Dean Man, School of Health Sciences. Your encouragement and support has been instrumental in making this symposium a grand success. Put your hands to welcome our team, Dr. Pushpa Sarkar. I would like to call Dr. Vino to welcome Ma'am Florally. I would like to welcome Dr. Ganesh, Principal and Professor of Nitya College of Physiotherapy, Bangalore, Florida. I would like to call Sanjog to welcome Prithviraj Sir, Principal, Army College of Physiotherapy. I would like to call Vimasha to welcome Mallikarjun Sir, Dean School of Physiotherapy, Acharya Institute of Physiotherapy. I would like to call Vimasha to greet Pradeep Sir, Principal, Vemana College of Physiotherapy. I would request Sitesh to florally welcome Dr. Raghavendra, Principal and Professor, College of Pharmacy, DSU. I would like to call Gayatri to welcome Rishikesh Sir florally. I would like Gayatri to welcome Bala Sir from Vesoma florally. Yeah, without further delay, thank you so much for joining us on this journey from soul to soul, a national symposium of DSU with the theme of, soul to soul, a better living. Thank you so much.
Thank you, ma'am. Now I would like to call upon Dr. Swapna Rao to welcome Principal Ma'am Florida. The release of a souvenir marks a significant milestone in any event, capturing the essence and memories of the occasion. This special keepsake not only commemorates our gathering, but also serves as a testament to the hard work, dedication, and collective efforts of everyone involved. As we unveil the DSU National Symposium 2024 souvenir, let it remind us of the knowledge shared, the connections made, and the inspiration gained during this remarkable event. I request the dignitaries on dais to unveil the souvenir for National Symposium 2024. Thank you, dignitaries. Ladies and gentlemen, it is my great honor to introduce our esteemed chief guest for today, Sir Petros Sidderes. Sir is a director of football at Bangalore International Football Academy, bringing a wealth of experience and knowledge to the field. With a distinguished career spanning over 2 decades, Sir Petros has led various significant positions, including Managing Director at Bangalore International Football Academy, Technical Head of High Performance Coaching Program at Bangalore Youth Football League, and Technical Director at Boca Junior Football School, India. His expertise in directing and coaching soccer players and coaches is complemented by his profound knowledge of creating technical budgets and managing related expenditure. Sir has an extensive background in international sports programs and player development system, and he is known for his discipline, adaptability, and innovative approach to coaching. His remarkable ability to collaborate effectively with club stakeholders and players and parents has made him a respectable figure in the football community. Please join me together to welcome today's chief guest, Sir Petros.
Introduction. Thank you very much for having me here. I will be quick in the learning for Singapore. So much knowledge and specification in your industry. I'm a football coach. I come from Greece. I'm here 10 years in India. I'm happy that that country has welcomed me so amazingly and have given me the opportunity to meet some amazing people, some amazing people I met today also. I don't have a lot to say in terms of technical aspects of the health industry. I can tell you 2 or 3 things from my personal experience as a player. How well I remember when I was a player, I played football for more than 20 years. How well I can remember the physios that treated my injuries. And I can say that I have found so much quality as a coach here in the last 10 years that I know Dr. Bala, and I thank you personally for inviting me to this event. I have met so much quality in terms of human and in terms of specification in the physiotherapists that I'm in direct relation to them as a coach. If I can give an advice to all of you, obviously your teachers are more qualified for that, and the programs that you follow that prepare you for what is happening in the real world outside of the rooms of the university. I will follow your quote. I would say to you, I know that all of you want to be successful and you need to have short-term and long-term goals. But for me, personally, what is important is that your soul in what you do. I assume that all of you that you are here, you are loving and you are passionate about the healthcare and treating people. Additional to the skills and the quality that comes out of that, my advice is put your soul in that, because this is the only way that you will be remembered. And that is what will stay at the end. Success will come and go. It's very important to be remembered by the single people, because from where we start and where we go, all of us we have the same soul. Thank you again for inviting me.
Thank you very much, sir. Now I would request Dr. Pushpa Sarkar, Dean of School of Health Sciences, to felicitate the chief guest for today. Thank you, sir. Thank you for your speech and addressing our gathering today. It was wonderful to hear from you. Now, I would like to introduce the guest of honor for today. Dr. Pushpa Sarkar, ma'am.
Yeah, we have chief guest of the day, Mr. Pedros, principal, Professor Satya Prasad, and we have the esteemed guests here, all the dignitaries from various institutions, the head of the institutions. So I am really honored to have all of you here together. It's so wonderful to see the entire fraternity here, the principals for the, it will take time for me to mention all the names, forgive me. So that shows the committee what our faculty, physiotherapy have with you all. It's like a family, and thank you so much for being here. Yes, special thanks to Srihari and Dr. Vinod. Both of them. And of course, all my young faculty members of physiotherapy, they are always cheerful, so active. And all the delegates who have come here are in-house, and all the delegates who I see are from various parts of India. I'm so delighted to see this, your interest for being physically here. Yesterday you had an online session. Symposiums don't go on for 3 days. Tomorrow you have post-symposium also. So to hold the interest of yours for 3 days, it's really phenomenal. I congratulate Dr. Satya and her team. Successful event. In fact, when they approached me, I was telling Satya, this field is not is rarely tread upon. It's not a very explored. It's been explored very much. This podiatry. So I was asking her, will you click? Is it important? Do you think people will be interested in this? And it is not restricted to physiotherapy. Right? It's also a medical field too. Like when you say podiatrist, we say medical doctors, and many times. So I was asking her whether will you click in this in creating interest in the physiotherapy faculty, because it's not solely a physiotherapy domain. But they were very confident. They said, "Madam, we'll do it." And when I saw, to be very frank with you all, when I saw her registration fee of 3,500, I said, "Really, people will pay this to come here?" And charges extra for the post symposium too. She said, "Yes, madam, we'll try it." And their target was 130, and she's met it. Her target was just 130, she said. So, and the entire team of the College of Physiotherapy have come together. You can see all of them participating here, all of them, they took individual responsibility, ably led by the principal and the senior faculty, Srihari and Vinod, and also Santo, Faber, all of these. And they've come up with a good show. Congratulations. Whenever I come for inauguration or a talk or whatever it is, I don't want to dwell much to this. And this is a very beautiful thing where I said from soul to soul, right? and we all are standing on our feet, right? All of us. So people say that, right? To stand up. In other terms also, I don't know how many of you understand Kannada. They say "Nimkalme Nimikobe." That means to say you must settle in life. You should be independent. So this standing on the feet is taken to that extent also. So how important the feet is being, like, the importance given to the feet is so, right? And they say that I don't know, because I never believe the statistics of, incidents when we talk in medical terms. Every author will be saying their own country. Now, if you read Davidson, if you read Harrison, like I'm being a medical doctor, I'm just in the medical books and telling you. So they will be writing what is going in their country, right? So not across, because many a times the statistics is not taken entirely. But they say an average human being walks around 1 lakh miles during his life. But I think nowadays it's more because everybody is addicted to the 10,000 steps per day. So maybe that takes much more now. Because I see many of them addicted to this. Everybody with their smartwatch or with their phones, they're counting, oh, today is 6,000, today is 5,000, and they go on with this, right? But however, what I'm saying as physiotherapists, all of you know that you are healers. Right now, I give a lot of importance to your field because I call you as healers. People come to you with deformities, pain, restricted movement, and you see to that they walk back again with full movement, and that's so great, I tell you, because for every human being, movement is very important. They don't know that until you have a restricted movement. See, I have a shoulder dislocation, a subluxation actually. Even today, I stopped playing badminton or tennis because I cannot do this backhand stroke. After that, I'm not able to do this. So only then we know how it is restricted. When you lose the mobility, only then you know the importance of that. Otherwise, you don't appreciate, that you are so normal. So it's very important that this podiatry has been. I read through I did the survey, and in Bangalore we do have podiatric clinics. I was not aware. I'm really sorry for my ignorance. There are clinics entirely for podiatry. I saw so many of them well-known podiatrists in Bangalore. I saw many clinics regarding that. So I thought the public awareness must be there and they must be having good patients. That's how they're running these hospitals and clinics solely for podiatry, right? So you should, because they're standing on their feet, so much of pressure on that all the time, you're walking, standing everywhere. So we need to take care, right? So of course, diabetic ulcers and all is second part. But you do have deformities. We have the national coach here, and from Mesoma we have people here, and US physiotherapists would have come. People come in with injuries. Correcting that is a big problem, I tell you, particularly in the feet. Right? When you have this tendinitis or a tear or a ligament tear or whatever it is, you're crippled. Elsewhere you can move, right? Not with your feet. So all of you please explore this much more. And there are all resource persons are here who are really into it. And amazing research has been happening. I got to interact with Dr. Rishi here, and he's doing amazing work. I'm really very impressed by. That is for a long way for the humankind. And if you succeed in it, sir, please let us know. So all the very best to you in your research field. So I just don't want to take much of your time. Only small thing, please don't take me wrong. Whenever I come, when we were students back then, even in medicine, we would rush to the class so that we occupy the front seats, right? So whoever it was, the others went behind. So we were in a, we always used to rush to the class so that we occupy the front seats. But always nowadays when I see all the front seats are vacant, people want to, they start from above. Then I think maybe it's a different culture because you're sitting in the balcony. So you don't want the front thing, it's balcony seats, high funda seats in the balcony. So the front seat is Gandhi class. That's what they call, the cheaper class in the theater. That's why maybe you would prefer to go, the back seats. But wherever you are sitting, please listen to people. Please imbibe whatever it is and take the best because you have come from all far off places and make the most of this. Have a great day. Have a great interaction. Please meet your research person and get to know what they're doing. You'll learn amazing things from them, right? So all the very best to all of you. Take care.
Thank you so much, ma'am, for addressing the gathering. Now I would like to request Dr. Professor Satyaguru Prasad to felicitate our dean, ma'am. As we come to the end of the inaugural session for the symposium, I would like to extend my heartfelt gratitude to all the colleges who have contributed in making our recent symposium a success. I would like to name all the colleges. I would like to thank RD College of Physiotherapy, Acharya NR College of Physiotherapy, Indian College of Physiotherapy, Bangalore, East Point College of Physiotherapy, Bangalore, Ramayana College of Physiotherapy, Bangalore, Vemana College of Physiotherapy, Bangalore, Prudence College of Physiotherapy, Bangalore. Now we have other colleges from outside Bangalore. I would like to thank them as well for participating online as well as offline. I would like to thank Lakshmi College of Physiotherapy, Bangalore, STM College, Dharwad, Government College of Physiotherapy, Ahmedabad, Wells College of Physiotherapy, Chennai, NIMS College of Physiotherapy, Jaipur, MGR College, Chennai, Vistas College, Chennai, B.R. Nath College, Andhra Pradesh, Yanapaya College of Physiotherapy, Mangalore, Sumandip Vidyapet Gujarat Physiotherapy, College, Gujarat. The list is endless, and I would say we all had 21 colleges together participating online and which is great. Thank you for being a part of this symposium. Now, I would like to call upon Dr. Srihari Sharma for the vote of thanks.
So, I would like to quote a few lines of Someshwara Shataka. Okay, so that is a literary work in Kannada. Of course, it is in old Kannada, Hale Kannada. It says, Kelavam Ballavarinda Kaltu, Kelavam Sugnanadim Noditam, Kelavam Sajjana Sangadinda Larial, Sarvagna Nappam Naram. Means, for a man to become proficient, so there are various things which he has to undergo. Probably some of them, or you have to learn through people who have already learned. You have to learn through observation, you have to learn through contemplation, and merely having a good group of people around you will make you learn. So probably this is one of the efforts from the College of Physiotherapy, Dayanand Sagar University, to create a platform for all the delegates to pursue their learning experience. Respected chief guest, delegates on the dais, dignitaries on the dais, dignitaries of the dais, and respected delegates who are present here. And I feel honored and privileged to propose the vote of thanks on the memorous occasion of the inauguration of our national symposium titled The Soul to Soul Taking Steps Towards Better Health. So, it was hosted by the College of Physiotherapy, Dayanand Sagar University. Today it marks a significant milestone as we gather here to exchange knowledge, ideas, and perspectives that will undoubtedly shape the future of our academic pursuits. First and foremost, our heartfelt gratitude goes to the chief guest of the event, Mr. Petros, Managing Director, Bangalore International Football Academy, for his gracious presence and the words of wisdom and words of experience. Thank you, sir. Thank you for accepting our invitation and being a part of it. I consider it my duty to acknowledge the unwavering support and guidance of our patrons, Dr. Hemachandra Sagar, and his Chancellor of Dayanand Sagar University, and Dr. Premachandra Sagar, Pro-Chancellor Dayanand Sagar Universities, whose futuristic vision has been escalating Dayanand Sagar University to greater heights. We are deeply thankful to our esteemed Secretary, Sri Gadi Swami, who has always been supporting to us. And our special thanks to the esteemed mentors, Dr. Amit Bhatt, the Vice Chancellor, Dayanand Sagar University, who was present yesterday for the inauguration talk online with us. So we would like to thank in absentia. Also, we would also take this opportunity to thank the Registrar, Professor Puttamadappa sir. He was supposed to attend the inauguration ceremony today, but due to his schedule, which was scheduled at the end moment, he could not make it up. And he has sent us all the wishes for the success of this event. Thank you, sir. The inspiration behind the events and all the activities of College of Physiotherapy, of course, the School of Health Sciences, Dayanand Sagar University, Dr. Yes, I is also here with us. Dr. Tushar Palekar, Dr. Sundar, Dr. Praveen Aaron, Dr. Prithviraj sir, who is again here with us, Dr. Ravi Saundatti, and many other people who have been guiding us through as advisory committee and who has given inputs for the successful execution of this today event. A special note of appreciation goes to all our distinguished speakers, panelists, and presenters who have graciously shared their experience and research findings. Your contributions are invaluable in enriching the various topics, our knowledge in various topics in podiatry. To our sponsors and partners, thank you for your gracious support. Your contributions have been essential in bringing this event to life and ensuring its success. I extend our sincere thanks to the organizing committee and a special thanks to all the voluntary members, student volunteers who have meticulously planning and their tireless effort have ensured the smooth conduct of this event. Your hard work behind the scenes have not gone unnoticed, and it is truly commendable. Thank you. We are grateful to all the participants from various institutions who have traveled from far and they have joined us in person and online. Thanks for the technology, and I would like to thank Mr. Imtiaz, who has been supporting us for the online transmission of all these events. And thank you very much, sir. I take this opportunity to thank Mrs. Kavita Kumar, who is the manager of the Informatics Publishing Limited, who has been coordinating with us for publishing the scientific proceedings of the symposium in the ISBN book. Thank you, ma'am. On behalf of all the members of College of Physiotherapy, Dayanand Sagar University, I would like to acknowledge the presence of the representatives from the media. Thanks for accepting our invitation and being present with us, sir and madam. I would be failing in my responsibility if I would not acknowledge each and every one of you in the audience. Your presence here today signifies your commitment to academic excellence and the pursuit of knowledge. Thank you, one and all. Lastly, I thank the caterers, facilities team, and the housekeeping for their support. As we embark on a journey of learning and discovery over the coming days, let us carry forward the spirit of collaboration and academic inquiry that defines College of Physiotherapy, School of Health Sciences, Dhananjay Sagar University. Thank you, one and all.
Thank you, sir. Thank you for your vote of thanks. Now I would like to welcome Professor Dr. Sai, Principal Sanjay Gandhi College of Physiotherapy. I would request Dr. Sanju to floorily welcome sir. I would also like to welcome Professor Dr. Sri Ramanathan, Principal, Vaidehi College of Physiotherapy. I request Dr. Sanju to floorily welcome. Thank you, sir. Thank you, ma'am. Now, as we come towards the end of the inaugural function, I request you all. I request all of the principals and the resource persons of the day to please join us on the dais for a photograph. I request all the principals and resource persons to join us on the dais for a photograph.
Okay, ready? Smile, smile. Okay, thank you.
you all to please stand up for the national anthem. Again, I request you all to please engage in the national anthem and sing it with your family.
पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, everyone. Now we'll be proceeding for the lunch. I request all the delegates that we are breaking for the lunch now. By 2 o'clock, I request you all to please come back to the auditorium. Delegates, I request you all to come back to the auditorium by 2 o'clock. We'll be
The college also comes with a lot of labs, such as the community-based rehabilitation lab, the electrotherapy lab, where we have well advanced modalities like the combination of laser and ultrasound.
हमें लोग थे
Obstetrics and gynecology, orthopedics, intensive care units, and so on. The college also comes with a lot of labs, such as the community-based rehabilitation lab, the electrotherapy lab, where we have very advanced modalities like the combination of laser and ultrasound.
we have a well set up dedicated faculty.
Yes.
I'm ready, Sai Bhavani.
Is it audible? Is it audible?
Yeah. Can you start the session?
Is it audible?
Yes, you are audible. Am I audible to you?
Yeah, yes, sir. Yes, sir. Yes.
Yeah, can we start the session without much delay?
Yeah, sorry.
Without further delay, can we start the session?
Yes, sir. Just in 2 minutes we are starting.
Oh, I've been waiting till from 11 o'clock. Oh, correct, no?
Yeah, it's a sorry for the inconvenience. I'll just give you a call. We'll start. Thank you, sir.
Good afternoon, everyone. We'll be starting with the session, plenary session 3 for today by Dr. Arun Maya on the topic assessment and diagnosis of diabetic foot. Dr. Arun Maya is the Dean of Manipal College of Health Professionals and Professor at Department of Physiotherapy. He is the head of chief for the Center of Diabetic Foot Care and Research at Mahe. Sir is heading the prestigious research grant funded by the World Diabetic Foundation. Diabetic Foot Care Stepping Ahead. Sir has various national and international publications. He is a recipient of fellowship from Spokane Center for Global Health, the University of Alabama, France, and clinical podiatry certification from Indian Podiatry Association, and accredited foot balance medical expert from Finland Podiatry Medical Association, and have a membership of American Podiatry Medical Association. I would also like to welcome the chairperson for the session, Dr. Amit Gurande, Director and Chief Orthopedic Surgeon Services from Surya Hospital, Kolhapur. Thank you, sir. You may start the session.
Thank you. Just for the correction, the diabetic foot assessment and management will be discussed tomorrow. As communicated earlier, I'll be highlighting on the Charcot neuropathy assessment and its conservative management.
Okay, sir. Fine.
Am I audible to all of you?
Yes, sir.
So the outline of the presentations will be focusing on the definition, the pathogenesis, clinical presentation, as well as the management, focusing mainly on the offloading, footwear, and the Charcot neuropathy is also called Charcot neuroarthropathy. Sometimes we call it as a Charcot foot disease. This is one of the common complications or the microvascular complications associated with the type 2 diabetes. Once the neuropathic osteoarthropathy is affected, it affects the bone, joint, soft tissues of the ankle and the foot through a localized inflammatory process. As I mentioned, this is most commonly seen in the diabetes mellitus population. Other causes also may be spina bifida, syringomyelia, infection, alcohol, meningomycin, as well as the spinal cord injury. With respect to the Charcot foot associated with the diabetes, initially it starts with the early neuropathic changes like the decreased sensation. As the sensation gets compromised, patient doesn't know when they are walking barefoot. Predominantly, they put a lot of load on the forefoot and the midfoot, thereby the midfoot structures start get damaging. This is one of the most common reasons for or the clinical changes we see in the Charcot foot. So the joints becomes disorganized. There is a collapse of the bone. Why this happens is, as I mentioned in the beginning, it's an excessive inflammatory pathology, an abnormal blood flow, increased osteoclast activity. There is a bone destruction rather than the bone formation that leads to the reductions in the bone cell. Then there is a complete loss of arches or the collapse of the bone. Glycolization of the ligaments, as well as then once again there is a structural pathologies or the damage like the joint collapse. Most commonly, along with the clinical manifestation, the Charcot neuroarthropathy is also characteristically diagnosed with the radiology. As all of us know, in a normal foot, we have the hind foot, midfoot, as well as the forefoot. Hind foot is predominantly controlled by the calcaneum and talus. The midfoot is predominantly by the naviculum as well as the cuneiform, and the forefoot is mainly by the metatarsal. The stage 0, there may be an edema. Clinically, the patients will have the edema. increase in the temperature, but however, if you look at the X-ray, not much structural changes develop. Because of the abnormal of the uncontrolled blood sugar level, this is a very rapid or the fast developing pathology. The stage 1, there is an initial bone resorption, bone fragmentation, and then the joint dislocation. Then the stage 2 is usually also called the coalescence, involves the bony consolidation, osteosclerosis, fusion after bony destruction, absorption of the small bone fragments, fusion of the joints, and the sclerosis of the bone. Then the stage 3 is usually called a reconstruction. However, the reconstruction will not be as expected like the healing of the bone following the fracture. But here, most commonly, an abnormal changes develop, decreased osteosclerosis, progressive fusion, and healing and new bone formation, but not in the regular fashion. And once again, this leads to the deformities like it leads to the deformity. There are changes in the joint configuration and also can lead to the dislocations of the bone. The pathophysiology, as I mentioned, the peripheral neuropathy is the most common reason for the developing the Charcot foot in diabetes. Along with the peripheral neuropathy, the vascular changes, if there is a compromised microvascular circulations or the microvascularity, these two are important pathophysiology for an abnormal bony changes and the joint changes in the Charcot foot. Loss of sensation. Then also there is a arteriovenous shunting leads to the increased bone resorptions and the osteopenia. The clinical manifestations, usually the patients comes with the swollen and foot. Most of the time we think that it could be due to the cellulitis. However, in the diabetes, along when you are differentiating for the cellulitis, it is also important for us to rule out the Charcot foot in the diabetes population. The palpable pulses, because the vascularity may not be much compromised, and the neuropathy, but when the swelling is there, when the pain is there, usually the altered vibratory perceptions at threshold or the monofilament test is also a little challenging because of the edema, because of the pain, the patient may not able to report an exact changes with the neuropathic parameters. In the detailed evaluation is very, very important. However, tomorrow I will be going in detail about each evaluation. Most importantly, in the Charcot foot, we need to go for the detailed evaluations focusing on the neuropathic assessment. And if you suspect the Charcot foot, clinically means there is a loss of arch or there may be an abnormal, the bony changes, especially the medial aspect of the midfoot becomes very prominent. In those cases, the detailed plantar pressure analysis is very, very important. This helps to provide an appropriate footwear in this population. Significant temperature difference between the feet is the one important presentation. History of trauma. Then, if there are any other soft tissue infections or the cellulitis in the later stage can also increase the risk for developing the Charcot in diabetes. As I mentioned, always rule out these differential points, whether the patient is having any gouty, along with the blood parameter, along with the complete blood picture. It is important for also to check the gouty arthritic changes. Then the cellulitis, look for any inflammations and the infection. Also, perform the Homan sign to rule out any deep vein thrombosis. These are the three important Ds commonly seen in the Charcot foot. The first one is the degeneration, destruction, dislocation, deformity, debris, and the dent. These are the characteristics findings you see in Charcot as the charcot gets advances from the stage 0 to the stage 4. Most important is the treatment. Treatment can be the total contact cast is the actually the standard care or a very important line of management in prevention of the further deterioration of the charcot in type 2 diabetes mellitus. However, the total contact cast has its own strength and limitation, considering the most of the time patient says, I don't have any fracture, why I should need to wear the plaster of Paris. So, and adherence to that is very, very challenging. Therefore, we have the various other advanced footwear or the shoes are available called the air cast boot, and sometimes the strict immobilizations is required, and normally in the stage 1 and 2 a minimum of 3 months of complete immobilization either with the strict TCC or the rigid footwear is essential. Stage 4 predominantly the orthopedic surgeon's consultation is essential whether to treat conservatively or need any surgical intervention. So this is the most important line of management. Any suspected charcot foot, usually we call it as the rocker bottom footwear, needs to be given. You can see the patient, the loading is completely, basically the design in such a way that the transition or the shifting of weight will be very, very smooth from the hind foot to the forefoot. Or most commonly we use called the crow, it's called the charcot restraint orthotic walker. This is slightly quite expensive. In Autowalk or other companies are providing this. However, if you have to educate the patient, you have to sensitize them about the importance of a very strong, rigid footwear to prevent the further damage. Or otherwise, usually we should go for the rocker bottom footwear. In summary, osteoarthropathy due to the diabetes-induced neuropathy and the trauma is basically because of the uncontrolled inflammatory process. Acutely swollen hot foot, clinical diagnosis with the radiology is must. Primary treatment is offloading. Surgery may be required. In the physiotherapy, along with the offloading, we also go for the other pain management and the structured exercise-based rehabilitation that we will be discussing in the tomorrow's session. Thank you all. Any questions? Any question? Hello. Hello.
Hello, sir. There's no questions
Okay.
from the audience.
Can I leave the meeting or?
Yes, sir. Yes, sir. Thank you, sir. Thank you. Where are the delegates?
Delay, we would like to proceed for the fourth plenary session, which is the last session for today, which will be held by Dr. Rishikesh Yadav Kurara on the topic plantar pressure evaluation in diabetic foot biomechanical approach to offloading footwear prescription. Sir is director at Footrest, Podiatry and Physiotherapist at Rehabilitation Center, Hyderabad. Sir has extensive experience in both academic and clinical practices. Dr. Rishikesh has numerous publications, grants, patents to his name, and his remarkable contribution has earned him various prestigious awards. I would like to call upon Dr. Rishikesh for the session. Chairpersons for the fourth plenary session, Dr. Malika Arjun, Principal Acharya, Menard College of Institute of Physiotherapy, and Dr. Praveen Aaron, Principal, Padma Shri Institute of Physiotherapy, on the dais, chair the session.
Thank you, for giving me the opportunity. Present myself to give a small insight on what a physiotherapist can do in the field of podiatry. Yes, we have limited, but most influential part in preventing, treating, and preventing the occurrence of occurrences that we have diabetic foot disease. So, solution on the slide. Good. Go ahead. In this brief of what happened in diabetic disease, there is an increase in the prevalence of type 2 diabetes mellitus in the Indian population, maybe because of poor lifestyle, overeating habits, and maybe stress. And see, about every 100 people, 90 people are suffering with diabetic mellitus. Out of 100 diabetic people, 20 to 49% are suffering with diabetic retinopathy. As we know, type 2 diabetes mellitus microvascular diseases, which will alter the blood supply to the every tissue, including the foot muscles, foot nerves, foot bones, joints, everything. This again due to complex So once we identify this factors as early as possible through the physiotherapy role, we can reverse. If you see, because of sensations, because of reduced sensations, there is a lot of pain, altered balance, which leads to putting high pressures in one particular region. If you see motor component, because of altered agonist antagonist mechanism, the foot proper mechanism is altered, which can lead to part in this pressure. Atomic neuropathy, where the sweat glands and the oil glands of the feet is reduced. It leads to the increased friction, can lead to shear forces, that can lead to high increased pressures. Altered biomechanics, because of hyperglycemia and glycation of the foot tissues, can lead to rigidity, can lead to high blood pressure. And vascular supply, because of food supply, there is no replenishment of the nourishment, can lead to high blood pressure. All these components together increases the load in the food, leads to ulcers. So the why we are going to see bronchitis? If we know early diagnosis, if we find out the early changes in the food, we can reverse it through our physiotherapy role. We can reverse it and we can prevent the food ulcers. And the person is having the ulcers also, we can reverse it and we can prevent the recurrence. Yes, definitely. As a team of podiatry, we have our role. What is to improve the inside forces, that is through joint mechanics, bone mechanics, and muscle mechanics, and outside forces, that is through ground. When we are walking, the ground is interacting with the foot, and the foot is interacting with the ground. When both are balanced, we can manage the blood pressures. If not, the repeated forces on the ground through ground traction forces can spoil the hip. What is the basics? The pressure, the plantar pressure or any normal pressure is directly equal to the forces divided by the area. It means the higher the pressure means higher the forces or lesser the area. So what is my role as a physiotherapist? What is your role and my role in managing the plantar pressure is once you know the basics. To reduce the area, the pressure, we can reduce the forces or we can increase the total contact area. And forces are numerator. We can once we manage the forces that are happening on the feet and increasing the total contact area, that is denominator, we can reduce the overall plantar pressures. So, what is my role as a podiatric physiotherapist in the team of podiatry helping the diabetic patients? First, reducing the forces. By improving the foot kinematics, by rehabilitation or physiotherapy or any modality, we can reduce the forces and by prescribing the appropriate footwear that can increase the total contact area. So by reducing the forces and by increasing contact area, we can reduce the plantar pressures, which have direct influence on the foot. Before knowing the foot pressures, we should divide the area into region of interest. Why? Because one particular maximum plantar pressure can have a different significance. We can't apply a single solution for all the problems. Every problem has to be independent, has to identify it separately, and have a customized tailor-made plan so that each individual area we can particularly focus in reduction the plantar pressure. How to measure plantar pressure? So as technologies are advancing, we have two kinds of measurements. One is a fixed rigid platform called plantar pressure plate, where it is fixed on the ground and patient walks on it. It has some advantages and it has some disadvantages. The other thing is much more advanced is in-shoe plantar pressure analysis, where a much more sophisticated sensors are kept into the foot. The patient is independent, can walk, we can track the entire day of physical activity, and we can measure exactly the high pressure on the increase. Once we know the data, we can identify which part of the foot is getting more plantar pressure, so that is the future risk of ulcers, and we can reverse it. Yes. Before going to the management, we should know what kind of forces are acting on the foot. The four basic forces are acting on the foot are the compression forces, that is, the plantar muscles, the fascia, the soft tissue is becoming sandwiched between the hard bones inside and the hard surface outside. These are the common forces. Tensile forces, mainly the plantar fascia. During the heel off and toe off, there's a lot of tensile forces acting on the plantar fascia to maintain the normal arch. This is altered in diabetic foot because of hyperglycemia of the collagen. So when there is no elasticity in the plantar fascia, there will be wear and tear in the plantar fascia, leads to early childhood shear forces. When we are walking, especially the heel, the foot goes in one direction and the ground goes in the opposite direction. These shear forces create a scissoring effect on the tissue, which can lead to cracks and ulcers. Combining these irrational forces, when we are turning, when we are shifting our position to different position and plane, these three forces, multiple irrational forces, further put lot of stress on the skin, which can lead to tearing of this one. Okay. These forces, which area we have a lot of plantar pressures happening. So plantar pressure simple is not a single identity, it has multiple components. First is average plantar pressure. That is entire forces acting on the total contact area. It's an average pressure. Next comes which you have to focus more on maximum plantar pressure. What is maximum plantar pressure? It is the highest pressure in one particular region of the interest. As we have divided the foot into 5, 6, 7, 8, like grade 2, medial foot, lateral foot, mid foot, hind foot, and whatever it is, that particular region, what is the maximum plantar pressure that is happening? So what is the cutoff? During the pedopalography, if the plantar pressures are below 500 kilopascal, that is fine. If that particular region, if your plantar pressures are very high, that's going beyond 500 kilopascals, it has proven that there is a high risk of foot ulcers at that particular region. Pressure timing figure, one more advancement. It's not only the maximum plantar pressure that is affecting in particular region, it is how much time the maximum plantar pressure is involved in that particular region. Normal gait, the heel strike to the door, it is almost less than 0.8 seconds. That is 800 milliseconds. Because of poor motor imbalance or because of poor sensory neuropathy, people try to put lot of time in one particular phase of the stance phase. That is equal to maximum plantar pressure is already occurring on that one, and pressure is multiplied with time. So combining this leads to much more devastating effect on the culture. Sometimes lower plantar pressure with higher time critical can also higher cause of ulcers. So not only focus on the maximum plantar pressure, but also focus on the how much time they are putting time during that contact time of the feet. Now one more advancement happening in the Kodiak is total foot inertial loading. That is, you are already putting maximum plantar pressure, that too multiplied with total amount of time and number of steps. So the real game starts here. One of the best medicine for diabetic people is walking. We are the able to walk at least 5,000 steps, 4,000 steps to control the hyperglycemia. But if you walk, this is happening. Maximum plantar pressure, more pressure time integral, more inertial loading, ulcers. The patient is not walking, blood sugars are increasing. Whatever you do, both the ways you are creating an ulcer in the foot or increase the risk of ulcer in the foot. What is my role? Identify them, find out the reason. Am I correcting the forces or am I correcting the area so that I can reduce overall maximum plantar pressure? One more thing is normal individuals, when we are standing, you and me, today diabetic, we tend to put more load on the heel. Means if you take a ratio of 4 foot maximum plantar pressure divided by the 9 foot plantar pressure, it should be always less than 1 because hind foot is designed for higher load taking and 4 foot is designed for the propulsion. But here is the thing. What interestingly happening is because of peripheral neuropathy and impaired balance, we tend to put our postural strain anteriorly, center of the mass anteriorly. So 4 foot is taking part of pressure. So when you do the ratio of 4 foot maximum plantar pressure by 9 foot plantar pressure, it is slowly increasing more than 1. And many studies have proven that if you are increasing more than 1, high risk of foot ulcers. And if the ratio, if the 4 foot pressures are higher, double than the hind foot, definitely guarantee you can do that in coming 5 years, this fellow is getting foot ulcer 2.6 times. So always reduce the maximum plantar pressure, reduce the pressure time integral so that you can increase number of steps, but also shift the maximum plantar pressure load from anterior to the posterior heel. Once you know this is your objective, You can use your own strategies, your own exercise therapy, your own rehabilitation, your own footwear, whatever, to keep these outcomes in touch. Yes, as a physiotherapist, with using exercise therapy as a modality, what we can do is we can improve the foot and leg biomechanics. This, as we know, most of the foot muscles are arising from the knee and thigh. So hip, knee, and ankle have direct and indirect role on ankle or foot biomechanics. Either overworking of the tight muscles or weak muscles or excessive eccentric loading or excessive concentric loading, this can put altered biomechanics in the foot. For example, normal person like me, when I am taking the gait, the first thing is heel strike. During the heel strike, foot is in dorsiflexion, right? But because of motor neuropathy, in dorsiflexion, what is happening is it is the lengthening of the calf and concentric activity of the legs and legs. Simple. But because of motor neuropathy, the eccentric loading of the legs and legs is lost. So during heel strike itself only, when foot is in the plantar flexion, that is heel strike and touching the heel as well as forefoot. And again, forefoot, just focus on the eccentric loading of the tibialis posterior. If you see high heel ulcers, it is mostly because of the tight or like ligated tendon of the endogenous. Because tendons are building in collagen, collagen helps water. When you drink the water, it is a hydrophilia. But once sugar is entering, the glucose entering into the game, the water is replaced by the glucose molecules in the tendon, leads to tight muscles or tight tendons. This leads to hindfoot valgus or hindfoot valgus, where again during the heel strike, instead of entire heel is touching the ground, only one side of it is touching. It will get medial heel ulcers or lateral heel ulcers. What is the correction is start early stretching the calf muscle and release of the tendon so that it can reduce the load on the heel. So this is our role controlling the flow. What is offloading? Outside forces. When I'm touching, when my feet is touching the ground, the foot and the ground are interacting with each other. I have two weapons here right now to reduce the lateral pressure. One is insole modification and one is outsole modification. And insole modification, what I do is yes, as per the latest guidelines by Australian food guidelines as well as International Working Group on Diabetic Food, they have released some statements regarding if you find during pressure mapping, if you find one particular region has high blood pressure, you can modify the source. If you see if it is at great low, if it is a medial force food, if it is a lateral force food, or the mid food or the hind food, by simply modifying the insoles, we can redistribute the plantar pressure. My dear students, don't reduce the plantar pressure, redistribute the plantar pressure. If you are reducing plantar pressure, the reduced pressure goes to other part of the foot and creates secondary ulcers. Always redistribute the plantar pressure, don't reduce the plantar pressure. That is the main motto of offloading. So, as you have once I get the plantar pressure mapping, I can choose any one of the insole modifications and I can give it to the person, follow for the 3 months where I can redistribute the plantar pressure from one to that particular region of interest. So we have a lot of method. One is modeling method, one is detection method, one is custom method. Where we can scan the feed, we get the data, we can modify it, and we can model it as per the patient food pathology, so that that particular area is offloaded and the force is redistributed across the feed. Outsole modification. Now, insole is over. Now, outsole. What is my role? We have a lot of rubber or the mechanism available for the food, depending upon the kind of food deformity we have. For example, if the if you see the ankle has a limited choice of the ankle has limited joint range of motion because of some injury or any sharper foot, we can go for ankle proper also. If you see the injury is at the midfoot or distal region, you can just proper the anterior part of the foot where the foot will be rolling off without putting maximum pressure at the anterior foot. But if you have any injury at the metatarsal area or first metatarsal area, you can just only proper the anterior part of the foot so that there will be no pressure in the anterior part of the foot. Now, if you see charcoal, it's interesting. If you see a midfoot collapsed charcoal foot, how to reduce the plantar pressure is just increasing the angulation, keeping the foot in the dorsiflexion and keeping the anterior rocker. This will reduce lot of shear forces, lot of tensile forces, lot of compressive forces at the midfoot so that there will be no further degradation of grade 1 charcoal to grade 2, 3 or 4. So we can play with our also modifications or its modifications so that we can improve the forces at the feet and reduce the time of rehabilitation. So once the ulcer comes, it takes a lot of time, both effort from doctors, family, medical system. So once you involve using effective strategies, we can reduce the time of duration of treatment, contributing our part of biomechanics into the body. One more. Before giving the insulin also, there is one more gate called footwear assessment. We can't prescribe every footwear to anyone. We should go for thorough evaluation of footwear. How is forefoot rigidity, midfoot rigidity, professional rigidity, heel cup rigidity, what is the height of the heel, height of the foot. So there are a lot of mechanics are available, lot of tests are available. Before prescribing any footwear, as a physiotherapist, we have a lot of measurements and there is a scale called footwear assessment scale. So you can diagnose or you can rate your own footwear what it ranks. Usually for diabetic foot, if you the footwear which ranks around 8, 9, 10, 11. So if the foot is viable, the foot is soft, the foot is deformity, foot is unstable, and foot is flat, we go for the ranking of 8, 9, 10, 11 kind of footwear. But if the foot is rigid, best cavers, or some kind of stability required for the sports, we go for the 3, 4, 5, 6 rank of the footwear. So keep this scale in your dictionary or in your phone or whatever. Whenever you are prescribing the footwear, just write what is the current status of the footwear right now, the patient, and if the scoring is less than 7, go for the 8, 9, 10 level kind of footwear, which can reduces the lot of shear, rotational, compressive forces, and can give stability to the foot. So we have done a lot of research for Indian population as part of my doctoral thesis, along with collaboration under the guidance of our Dr. Manipal. We have found out that definitely customized inserts have a significant effect on reducing plantar pressure. So every foot is different, every action is different. So assess the patient during static and dynamic, get the data, give a customized insert that has an excellent clinically and as per the research can reduce maximum plantar pressure and can reduce the future risk of ulcers. And also, there are some modalities in our physiotherapy, like laser shoe. So, along with myself, my colleague of Radhika, and again Manipal, we have developed a novel laser shoe. During the early stages of neuropathy, when symptoms are very mild, because of outer sensation, they have plantar pressures. Once you treat the early signs of mild neuropathy, we can reduce the risk of foot ulcers. Presently, right now, we are myself working with IIT Hyderabad Biomedical Department, where we are working on early prediction of foot ulcers. So once you get a foot ulcers, there is a lot of treatment, lot of diagnosis, lot of management. So my question is, why the person has to go to the foot ulcers? Why can't we identify as early as possible, identify the risk, and reverse it so that we can stop the person going for foot ulcers? So it requires a lot of infrastructure, lot of technology, and lot of accessibility. So as a collaborative with IIT Hyderabad, big team of engineers, doctors, and biomedical engineer scientists, we are developing a soft wearable device where we can measure the 5 outcomes which are as we have seen in the first slide, the 5 parts of the diabetic foot which are contributing to the foot ulcers. Once we have a wearable device in our own setup where we can identify these altered mechanics, we can reverse it. Thank you, Dana Center University, Dean Ma'am, Principal Ma'am, for giving some question to present my topic. Definitely, guys, I'm a particular therapist. Before anything, I want you also be a part of podiatry. If you don't involve, someone will take over your position and spoil the things. Okay, because we have a weapon of knowledge for biomechanics. It's the greatest weapon we have. Once you collaborate with a podiatric surgeon or vascular surgeon for dealing with podiatry, your knowledge of biomechanics, your knowledge of kinematics, your knowledge of matter pressure can be an excellent add-on to the team of podiatry so that you can directly see how patients are improving faster. So take this opportunity, get knowledge of podiatry, involve in the team of podiatry, give your inputs, get the outputs from the patient, improve the quality in the field of podiatry. Thank you.
Thank you, Dr. for that concise and comprehensive presentation on transfer-free validation in diabetes. I have two questions. One of the questions is personal clarification. One of the recent advances in pressure evaluation that I came across is for finite element analysis.
Take focus.
If you are able to just sum it up in 2 or 3 sentences, what is and how it is going to calculate?
The finite element analysis is a technology where we see interaction of each part of the food. For example, we can map the food because I am doing that I have very few modalities. I have divided the food into 5 steps. But in finite element analysis, it is a deeper biomechanics from the engineering part where they divide the food into 1000 components and 2000 components, and deeper and deeper they see how interaction of the each millimeter of the food is interacting with other things. So we develop advanced 3D scan elements, we make a 3D model. Then we see during different postures, different activities, we simulate it. Okay, if I get the data of the food, we simulate in the MATLAB or in the software. So we see each minute details. We require higher technology and it's not our department also. You require a very sophisticated biomechanical biomedical lab to 3D print it. It's an excellent device, sir. We can introduce it, but it will cost again. Because to scan the food in 3-dimension way and dividing it into the 1000, 2000, 3000 parts of the region of interest, it requires larger data. But as technology is increasing, maybe not that kind of sophisticated, if we get more basic things to scan the 3D way, we can enhance our prescription of the food weight. But my question is, as a physiotherapist, we should include even those topics in our syllabus so that when technology is arriving and the biomechanics students or physiotherapy students should know that what is knowledge. So unless I went to the kind of institutes, I came across this one. So a lot of work is happening again, large data, large algorithms, costly thing, but still it is much more effective, precise way to diagnose the forces acting on the food.
Thank you very much. The other question that I have is the process of offloading. Many types of insoles or things are used. And what is the difference between smart materials and memory foam materials?
Sir, for insole to prescribe, again still we have a guidelines of the show brand. So as per the International Bureau of Standards, we should only take A show 30 to A show 60. That means the tensile deformity forces of the insole. Memory foam, sir, it is one of the old crude material where once you put a force, the insole go for deformity, and once you remove the force, the deformity is maintained for some time. So that when you put the second step, it creates some kind of awkward. But the smart material is also called a textronics. It is textile plus electronics, but textronics, where they're developing smart smart textiles, which includes molybdenum and biological materials of the textronics where they each textile acts as a sensor. Now, hardly we are using 1,000 to 2,000 sensors in the food mapping, but textronics, each thread of the woven textile acts as a sensor. So, when you are putting like a wearing a socks, you wear a socks, the entire the ropes, the thread acts as a sensor. During walking, the deformity and the deformity of the textile create a reflex shock that is taken by the devices. Can you real-time algorithm? Again, this thing is included with the unified model analysis. Again, costly. My colleague, Christian colleague in the IT, he was measuring around one square inch of the material which cost around 8 to 9,000 rupees. Still, R&D is going on to make it more viable and available. But this memory foam is an old technology, not so suitable for diabetic food, but textile is the future where our textile, instead of like a smartwatch, my shirt can take my data, my pant can take my data, my socks can take the data because the fabric itself is a smart material which can identify the coding of the food.
Thank you very much.
Thank you, sir.
Dr. Vishwesh, it was a wonderful presentation. I would really acknowledge the work which has been done at unacquainted areas of physiotherapy practice. See, many times when we look at the crowd, looking into the aspects of a clinician, every patient we see, we call it as a diabetic city or a diabetes in the entire India. When we see a patient, what are those factors? Not all diabetes patients will end up with the foot ulcers, right? What are those factors which influence the cause for the foot ulcer? Because I really appreciate the work done, which happens as a retrospective way once you see the foot ulcer. Why don't we see in a prospective way, where we call it as prevention? When a patient comes to our clinic and say that, because every patient when I see PA shoulder or low back pain, patient says that I'm diabetes from 5 years, 20 years, 15 years. So what is that message you want to give all the budding physios when they see a diabetes mellitus patient? What are the do's and don'ts which they are supposed to educate the patient?
Very good question, sir. My my basic request is listen to them. When they say if they have diabetic mellitus more than 5 years, just take 1 minute extra and ask the question how your feet feels. Do you feel burning? Food looks fine. No scratch, no injury, no nothing. Food, beautiful food, no nothing is there. But they will suffer inside. The initial stages of the diabetic food is sensory neuropathy. They have burning kind of a pain. As the days goes on, right, they have severe burning pain, kicking pain, heaviness. They feel like they're walking on the rubber, they're walking on the water. Sometimes the patient that once in a while they say, my slipper is getting off, I don't know. We think it is a food weakness. No, it's not a food muscle weakness. It is the early signs of diabetic neuropathy, which leads to ulcer. Just speak to them. If the food is warm, food is cold compared to the food temperature. Food, do you feel entire food mechanism completely there? Do you have obstruction, mental pressure? Palpate the fetal pulse, palpate the dorsal speed, palpate the deepest posterior artery. These simple things, where we cannot spend even 1 rupee also, can get a lot of data. Once you find is in the screening phase, something is not normal, something is abnormal, then go for the higher centers. But at least touch it, feel it, and speak to the patient who had issues with the food. They may not come in for the feet issue, they may come on the neck pain, shoulder pain, back pain. If they have diabetes more than 5 years, 6 years, ask this, how do your feet feels? Can you feel hot in the bathroom? No, sir, I feel sorry. Can you try the same stairs of your home? Now I feel difficulty going like that. Do your slipper sleeps? Ah, yes, sir, actually. Do your nails move? No, sir, difficult to ask my no, my nails getting brittle. These are the evidence of neuropathy. Just spend some time with them, get the information. If you have, refer to the good identity.
Great, thank you. One last question which I want to put. As we come across these kind of bowling sensation or assessment is done, how do you differentiate the type of the ulcer which begins, which initiate at the stage of diabetes mellitus with other clinical features which mimics that? For example, recently I have come across some patients who has a diabetes for 20 years and he complains of burning sensation. We did all the examination. even the sensor methods were used, but it was found to be everything is normal. Later, it was found that his uric acid levels were very high. So, can you throw some lights on differential diagnosis of identifying the influence of diabetes mellitus on the food changes or history and other markers which will differentiate between those two?
Good question, sir. Usually this will confuse like rheumatoid arthritis, uric acid arthritis, or diabetic foot issues. So my question is, why to separate them? If they have a foot issue with diabetes, they are the highest volume. Okay, if I want uric acid is high, because of the uric acid is high, because of the forefoot pain, he may change his pain pattern. That will create another other part. So definitely, we are not a general medicine people to identify what the root cause. But as a, my arrow is my weapon is biomechanics. I want to focus on that one. Once I correct the biomechanics, practitioner can use some good food way or uploading food way. Let him refer to the physician. Let it be uric acid or rheumatoid arthritis or the cascade endorphins pulses. So diabetes may be a hero, but in the field we have other main roles which combine together as positive. We should have a thorough knowledge of biochemistry also. I agree with it, but it may be a pain or any unpleasant sensation. Patients start working on the other part of the food that will create secondary ulcers.
Great, sir. Thank you. Now it's open for the delegates. If you have any questions, there are few.
Yes, sir. Thank you. Actually, very informative message. Like a very wonderful session, I would say. You have spoken about the outside source modifications.
Yes, ma'am.
So after that, do the patient need to go like any training program from physiotherapist point?
Definitely. That's what I said. We are playing with the two aspects. One is the forces, one is the area. Area is controlled by the insulin also. But definitely increase the contact area through footwear and also reduces the forces of the foot by changing the momentum. That is by concentric training, eccentric training, balance, overload, or fitness. It's up to you, your game. So your part is reducing the numerator. Foot is increasing the denominator, that is increasing area. Both have to go together by overall reducing the maximum concentration.
Yes, in one source modification, we are just it is not straight, right? So for the modification is happening like that. So the patient may have the imbalances while moving.
Yes,
right? How to train them?
But usually, when you are going for the outsole, it represents already there is a chart for artery for the started. So there is a irreversible damage happening in the foot because of the chakra. Usually under the fracture, only for fractures and chakra, which is irreversible, we go for the outsole. But during that also, I'm not asking the person to walk for 10,000 steps. At least in the home, going for the washroom, going for the social activity, even take 1,000 steps. Even that 1,000 steps is not an exercise. Even that 1,000 steps multiplied with maximum mental pressure, multiplied by the offloading, can increase the total inertial load. So, though it creates a imbalance, it otherwise can advise a walker. My question is, how to reduce the pressure on the foot? Even with the walker alone, it will reduce the foot pressure. But if I add on this rocker bottom mechanism, it will improve his functional mobility. So he can functionally move from point A to point B to prevent further fall risk, can advise skiing or walker or quick.
Thank you.
Thank you.
Thank you, sir, for your presentation. It was a very nice presentation. Sir, my first question is, should we include ultrasonography in early diagnosis of neuropathy?
Question is, ma'am, yes and no. Because two studies have been published last year, excellent studies. They have done that during the heal of go-off, as the increase in the glycation of the plantar fascia, there is a micro in the plantar fascia. So, ultrasound has to measure what is the tendon, what the tissue, length, strength, and the extensibility of the tendon. Second thing is, It is good for evaluating the fat pad. And in Plato, God has given two beautiful cushions for fat pads, which can prevent the friction at the plate toe when we give up and go off. Due to neuropathy, due to angiopathy or diabetes, this fat pad was frustrating. So when you have to pick up and go off, there is no cushion. Directly push the food to the skin to the bone, leads to fast food deformity. It has valgus or parasitic valgus. So if you are using ultrasound, definitely initial stage may not require. If people are at a stage of neuropathy, definitely a simple thing is just to palpate the plate toe. Okay, part of the plate toe. If you find it is very hard, advise to for the ultrasound. Do the ring of mechanism. The arch is not connected properly, advise for the ultrasound to measure the definitely.
Thank you, sir. One more question is there, sir. We can see that there is decreased myelination in the diabetic neuropathy in the later stages, and the people who are in chronic stage are not able to bear the load. Basically, the nerve is not able to bear the load. So anything should be done. So as a physiotherapist, as a treatment protocol, that we can include load in the nerve in the later stages, so that it is useful for their day-to-day activities and maybe it may improve their gait speed, and told that the gait speed is related to the foot ulcers. Anything load, anything to which we can provide a load to the nerves for its structural and functional changes, which is under the safety measures.
Clean gait, there is no significant changes have been seen in the nerve because nerve is once upon its own. Okay, it is one of the most adamant stubborn tissue in the body. When it wants to do this, you can take it. People are struggling. Many pharmaceutical companies are working on this for impedance of products to take the migration. As the physiotherapist, my question is, we will not improve the nervous strength, but we can improve the cross connections. We can improve the muscle nerve connections by activating different tasks. So whatever the life left in the nerve, we can activate the bone muscles. So that's an indirect way to activate the nerve. But once migration is gone, it is very tough to begin it. But that's what I'm asking. Why the person has to go to that level? Okay, that is not my requirement. As a first line of defense or line of action in the healthcare system, try to identify, prevent it, than going for the later stages of neuropathy. Maybe in your example, already nerve is gone, that can lead to cardiopathy also. That is irreversible thing. He may go for nerve grafting or go for such a correction of the foot. If it is worse, if the NCV is zero, if NCVs are very good, less than 40 milliwatt percentage, whatever, they do nerve grafting. Still, do grafting also is useless. One promising treatment right now available to improve nerve is stem cell therapy. Only few centers are there in India who are right now doing stem cell therapy by diabetics. So they are giving stem cells to see if the vascularity can improve the nerve regeneration. Still, it's under research, but it's too late.
So low testing provide the low for too many therapy or something, it might not give the result.
When you put in the load, you are creating microtrauma in the body, but there is no microvascularization. So your trauma is good if you don't have diabetes, but the microtrauma with poor vasculature, you are inducing the trauma into microtrauma.
Thank you, sir.
Some are very prone to cellulitis.
Yes, ma'am.
What has been your experience when it comes to food pressure as well as the type of ulcerations that people who are prone to cellulitis?
Zero pressure. Zero pressure. Already food is already diabetic food ulcer, and cellulitis is crying.
No, even prior to food ulcers being formed, there are people who are more prone to cellulitis.
Yes.
So, diabetic involvement has already started. So, what type of deviations have you been seeing in such?
Cellulitis is a classic thick red flag for me. If they come to me, I will say, buy a walker immediately, buy a frame, what food to make. Cellulitis is not part of it. Maybe cellulitis may spoil the kid, so I will advise for the physician. They may go for excess for compressions or 4 year bandage, 2 year bandage is up to them. Once when it's coming down, I can take something, but acute infection of cellulitis is a red flag for me. Because whatever therapy I do or food I can do, it can create friction because your volume is increasing, the interstitial volume is increasing. A small injury from my side because of flooding of the tissue can spread out. So the person will lose toe with my therapy, spoiling the gate, you can lose the test results. So it is classic red flag for me. Sending those, if any intervention is for me is buy him a walker. Buy him a walker, ask him to go for the pure non-weight training, do with the doctor and come back.
Thank you, Dr. Krishnan, and I'm sure from the interactions that this has been one of the very interactive and informative session, and I'm sure all of you are conveyed with the most recent studies. Dr. Rishikesh himself, along with Dr. Arunmaya,
We have a great blog, a great group, separate setup for diabetic food, Manipal, and another legacy also. So I can proudly say that the future therapist who has opened a potato lab in Hyderabad. They are ready to spend the money, just have a good idea. If plus them, money is not a matter.
thank you very much. Thank you, and I'm to the organizing team.
Thank you, Rishikesh, sir. And thank you, Dr. Mallikarjun and Dr. Praveenaran for a wonderful discussion. Thank you, sir. Sir, I would like to request you to felicitate Dr. Rishikesh. Thank you, sir. Now I would like to request Dr. Sanju and Dr. Kanchan to felicitate Dr. Praveenaran and Dr. Mallikarjun. Dr. Kanchan. Thank you, sir.
With the due permission from the organizing team, I would like to speak for 1 minute. This symposium is first of its kind. I would like to congratulate the principal team of DSU. As we advance academics, the use of ICT tools plays an important role. But to organize such kind of symposium, which is a blended or hybrid mode, as a pre-symposium, they did it online. I tell you, the team has meticulously done the wonderful job communicating to the delegates, be it participants, be it academicians, be it PhD holders, scholars, everyone have participated and they have done a wonderful job. I think great congratulations and big round of applause for our entire team. Thank you.
So much, sir, for your kind words. Now, we'll be moving towards the last session, which is the expert panel discussion. I would like to call upon Dr. Radhika Jadhav, Associate Professor, Acharya in our Institute of Physiotherapy, for the following session. Please give up a big round of applause. Good afternoon, all. So certainly, professional development is very important. Also, the continuous education is important in physiotherapy. And I think that is the reason this hall is full today. So, without any further delay, I would like to call the experts from the physiotherapy for the panel discussion we have planned on the topic professional development and education in physiotherapy. So, for this panel discussion, I would like to call upon Dr. Tushar Palekar sir, who is the principal of Dr. D.Y. Patil College of Physiotherapy, Pune. Sir will be joining us online. Our second expert is Professor Sai Kumar sir, who is the principal College of Physiotherapy, Sanjay Gandhi Institute of Trauma and Orthopedics. Third panelist is Dr. Partha Komileni. He is a chief of Neuro Rehabilitation Center at MS Ramaiah Hospital, and he is a founder of Dr. Vinod Kumar Kesi sir, who is an associate professor, College of Physiotherapy, Dayana Sagar. So, today's panel discussion, I would like to start with the Sai Kumar sir. So, sir, why continuous education is important and for patient care and for a best outcome, how it impacts?
Good afternoon, everyone. All right. So, thank you for involving me in this panel discussion. So, it's the most important topic as a healthcare profession. Because we are into a field where it is continuously evolving and continuous physiotherapy education, which is not confined to what we have read in the curriculum or read through the syllabus which is taught. So it is very, very essential that you keep updating your knowledge with your clinical practice in your setup, in your specialties. Because what you study in the college level is different to what you experience at the clinical level is different. With experience in variety of cases, the same case will not be presented in the similar way as you expect. So different patients present in different ways. So this all comes with experience, and with experience, with the expertise in the work areas, it is very essential that you keep updating your knowledge. And I always endorse that in your workplaces, at least once in a 15 days, you need to have discussions related to the cases and also review whether your plan of treatment is appropriate or is there any advancements, and invite some speakers or guest faculties so that they can come into that special area who can teach and enrich you with the quality of service what you can provide. So it is very essential from this point of view that you need to keep updating and have that education.
Thank you, sir. Definitely, we have to keep ourselves continuously upgrading. So, on the same question, I want to know Tushar Palekar sir's opinion. Sir, why continuous education is important and how it impacts the patient care?
Yeah, I would like to put down a few points. Sir has already put down that it is important. I would say it is very crucial and significantly required to enhance our profession at large. The profession has to enhance by keeping up ourselves upgraded in all the scenarios that is possible for enhancement of any patient care with their outcome measures that we have to always consider. So one is to keep up with all the latest advances that are coming up in the field. Secondly, it also helps in improving the clinical skills. Thirdly, it will be helpful in our specialization where our area of expertise and practice is going to prevail. So various areas that we need to progress as a part of the professional field, the continuous education that is required, which will be for physiotherapy, should be there for all the students and faculty also.
Yeah, thank you, sir. So as Sai Kumar sir said, like what we study in the books, maybe we don't use that most of the times in the practice. Very correct. Okay, even I have experienced the same thing, sir. So with that same question, I want to ask Vijay sir. Sir, do you want to suggest any additional credit courses, academic courses, national level or international level for our young physiotherapists?
Yeah, it's a very hard question for the discussion of professional development, what we are talking today. And yes, as we all know that physiotherapy, the field of physiotherapy has come a long way. Like as if I relate to myself, uh, probably a small town boy way back in 1992 when I dreamt of being physio. So yeah, so what I feel is learning is not something which stops. Learning is ever continuing. And as we have come to an era where we are talking about evidence-based practice or practice-based evidence, what we talk about. We practice what is an evidence, or we talk about evidence to what we have to practice. So when we are into that mode of learning and understanding the profession of physiotherapy, what I feel very important is probably there are a lot of things. The scope of learning is very vast, which may not cover in every syllabus. So, of course, as a universities or a college of interested colleges, they always emphasize on having some courses which are very important to that area of field of interest. Of course, we need to have this certification courses which enhances a student or a learner ability to understand that subject in depth, which may not happen in a classroom environment or things like that. So it is as a person to grow in profession, it becomes very important to acquire this additional certificate courses in the field of their interest. What I feel, and of course, I feel everybody here will agree for my point on importance of this specialized courses or certification courses. Thank you.
Thank you, sir. So my next question is to Parasati sir only. Sir, there are many interns, those who are attending today's workshop. So now they have finished their graduation, they have finished their internship. So now, do you want to suggest any one national or international course that you feel, okay, this is must, any physiotherapist has to do it? Either online, offline, anything?
Right. Yeah. I remember. So nowadays there is no dearth for the number of courses that are available everywhere. So I think it is again left to the interest of the person that they want to pursue. I feel like nowadays it's very difficult to pinpoint which is good course, which is not a good course. Right? Something that I might consider is not so good might end up to be the best courses available. Right? Today I have had the opportunity to listen to sir for the last 5-10 minutes. It was an amazing interaction, So you can I don't know what food appreciation was and food bariatric physiotherapy or not. If I write it off, then it's a standard that I have to create. So to identify what might be the right course, so I would recommend people who are interested to interact with the seniors, talk to looking for people that you believe will give you the right opinion, or if they're aware of the resource person, right? That'd be a better course and not a good course. Going for the credits, I don't believe in that. Go to learn from the right person is what I would recommend, right? So you have to do some research, which course you have to do, and it should really impact your professional careers. So one point that I would like to share here is, I see many people doing some 10, 15 courses in 1 year. They really don't understand why they are doing so many courses. You can't be master of everything. You can only be jack of everything, right? If that is the intention, you can do many courses. Suppose if you're interested in podiatric physical therapy, do attend continuously couple of such courses. You can, right? It's what, as a simple recommendation, I would suggest.
Thank you, sir. So I want to ask Kushal Parekar, sir.
Yeah.
Is achieving the outcome-based learning, what we are actually planning as per the new education policy, outcome-based learning. So, sir, do you believe in current physiotherapy education or current physiotherapy curriculum, are we achieving the outcome-based learning?
Yeah. So you are talking about the outcome-based education that is yet to come into the physiotherapy education field still. So we are still battling with the curriculum right now to come into a uniform platform. So once this uniform platform creation of the syllabus would arise, only then we will be able to go in for higher modality of teaching learning pedagogies. So outcome-based education is still a far away venture for us as what we see today. Today, we need to take up a step where all universities in the country should be on a similar platform of education. So we require this pattern, what the ministry has already given as a curriculum earlier in 2015. We are yet to follow that itself till date. Now the National Commission has come up and the curriculum task force has also built up a curriculum, and that needs to be implemented, possibly will be in force from next year onwards. So possible outcomes would be, first, the similarity in the education pattern all over the country, and later on we would think about enhancing the pedagogies in teaching learning at every level. That would be at undergraduate, postgraduate, as well as our clinical levels. That enhancement of clinical practice and expertise need to go up higher as per today's need of the patient requirement. So outcome based education will be a still further step, and we will have to look into it as quickly as possible in the near future. Otherwise, we are on a backward platform as compared to the global standards. So we need to march a little bit faster and start enrolling ourselves for getting higher standards of education. So I think most of the deemed universities are a part of the higher education and should follow what is required for today's skill development. So we should follow this. Outcome-based education would follow automatically later on. Thank you.
According to me, as a physiotherapy professional, our specific task is to target the functional outcomes. Any individual, irrespective of the condition, so whatever is suffering with, whether it is musculoskeletal related, neurological related, cardio related, so the only task for that individual, while a physiotherapist, is to
reach or return to his functional requirements. So what is the maximum functional achievement we can do? So that is what we need to focus on. Our curriculum should be designed in such a way that you give these functional goals rather than having general goals, aims and goals, what we talk about, relieving of pain, improving of range of motion. All these things are fine. Of course, we need to do this to achieve the functional goals. But majority of the people stop at that level. So we don't focus on whether that individual has returned to the functional their requirements. And that is something which is very, very important. Linked to that is quality of life. So quality of life is something which we don't usually focus on. So quality of life varies from person to person, individual to individual. So you need to note down when you talk about, for example, you have two patients of osteoarthritis. Osteoarthritis management is same for every one of us. But if you see based on the outcomes, functional outcomes, it is different for both patients. We need to talk about what are the functional outcomes for both of them. So to talk about what are the functional outcomes, you need to think about what is quality of life for them. So what is quality of life for those two individuals? It is entirely different. So these areas has to be focused in our curriculum. And if those, based on that, if you are designing the curriculum, obviously we are able to achieve much better results, and we need to have a very clear cut focused treatment plans.
Yes, sir, for the wonderful answer. So, as a physiotherapist, we deal with the patient care, we are associated with research. Also, the important role is research. So, where the physiotherapy research is going. So, I want to ask Parthasarathi sir. So you think like our physiotherapy research is growing in the expected manner?
I can't say it is in the expected manner right now.
I think there is significant improvement in quality of research that we are doing. Right, that's the big plus point that we see. But it's very sporadic. Right? It's very, very sporadic. There is a lot of research going on, a lot of publications that are happening. But what is the value of all the research that's coming out of many people? Right? That's something that the people at XI has to work on. What is the impact of research that's happening instead of but the number of publications are crazy. We feel very satisfied that not is happening. But sporadically, there are amazing researches that are happening. But I still personally a little dissatisfied that the majority of the percentages that's happening just for the sake of having publications. At least for the crowd here, there should be some change that I should create some change. I should create some impact. The outcomes that I get from my research. It could be fundamental research, it could be some outcome-based researches. That should be the thought process at least. Whether we land up with very great outcomes or not, that's secondary. But the thought process has to be driven in that direction. That we do decent research. We not just do it for the sake of having paper. It will be published, be presented for a scientific presentation. It might be hard to think, but that's something that I really wanted to share when I saw this question that you shared. So, but definitely there is a positive. It also be even more than. To be frank, I was not doing great research to start doing research. So at least let us not do research. People are not doing good. Yeah.
So you want to say that we should not just focus on the quantity of research, but we should focus on the quality, and more than that, if we are doing some research, we should definitely bring it to the patient practice, right? It should not be just for the sake of publishing paper. Unless and until we use it in the real practice, it sounds good. Very good questions. But based on that only my next question is for you only. So sometimes we feel we are losing connection between the theory we learn in the art curriculum, then what we are practicing on the patients, our treatment, and plus we are doing research. So sometimes we feel there is no connection between these three. So do you agree with this? And if it is so, what steps you should
that picking up these three pieces, theory, clinical practice, and then research. Right? They are highly interrelated. I have to say that they are highly connected. So only when you have the fundamental knowledge of the situation, will you be able to apply your therapeutic skills if you can solve those problems that you learn here. Not the theoretical information of how it now works. Like I discussed in the board. Now fibers, the myelin muscles, the interconnection between the microfibers to connectivity, stuff like that. All that could be assimilated or understood only when we have theoretical experience. When that information is there, theoretically when you implement something, you can understand what's happening or how these things. Theoretical information is happening. You get good results. If there is no evidence to that, you can do research to support your thought process. But if you're having the negative impact that your intervention is causing to that particular condition of patient or group of patients, you would have critical reasoning skills. That only comes with when you connect the theory with clinical practice. So to prove that, good or bad or okay, managed, right? You have to do the research. So I think they're all very well highly connected. Only when we connect all of that, we can come up with good research is my opinion.
Thank you, sir. Thank you for that answer. So now I want to ask Tushar Parikar, sir. Sir, I want to ask that how important it is for physiotherapists to engage in the interdisciplinary therapy and your experience about interdisciplinary collaborations.
The industry collaboration for physiotherapy is very crucial nowadays. We require to have academic and industrial marriage happening together. We need to foster the culture of getting this into the bloodstream of physiotherapy.
Interdisciplinary learning and interdisciplinary collaborations.
Yeah. With interdisciplinary collaborations, we have to have more of research collaboration first. We need to inculcate the nature of seeing what is required as a physiotherapist and what we can do with other pathies. Now, we are largely dealing with only medical, but there are some dental conditions. We are dealing with patients also referred from homeopathy and Ayurveda. There are various other alternative therapies which are available, and those medicines, stream of medicines are also nowadays referring to physiotherapy. These referrals are usually lost by a practicing physiotherapist also. So interdisciplinary mechanism of referral system is nowadays coming into the practice, which we also need to welcome with open arms and embrace it. We have to accept what are the different systems and what physiotherapy needs to be given accordingly we have to give. So we have to go in for interdisciplinary work, interdisciplinary clinical practice, interdisciplinary learning, translational research, as well as interdisciplinary research has to occur. The progress in this would be in terms of also research outcomes. Most of the interdisciplinary research outcomes are very well published also at international and national level journals, which are in high level quartile journals. So this would inculcate for much more citation for a research scientist for Indian scenario, as we deal with a lot of clinical material. So this must be encouraged as a part of interdisciplinary learning at the undergraduate level, and we learn more about research at the undergraduate level itself. Thank you.
So one more question to you only. Sir, how one should perform the self-assessment criteria for a professional development? Okay.
Respond to your previous question, right? So about the interdisciplinary approach, right? So every medical condition that we are treating, we should firstly think that we're not the only people who can this patient population, right? So we need to identify who are all the players who can work with this patient to get what the patient wants to achieve. Let's take it. I know my area is neuro rehabilitation. Let's take a stroke patient. As a neurophysiotherapist, we think that I can get the best outcomes for this patient population. Right? You might have one of the systems as that I'm the one who has to take one of this population. Guys, can we have your attention? Well, we're not here just to have fun and go spend our time. Hello. Right. If you like, always shut my content. Okay with us, Doc? Thank you. Right. We're talking about interdisciplinary team approach. It's a major element of this currency your plan. I was saying that it is very much because we're not the only healthcare professionals who have one patient. Let's take one patient is having a stroke. Let's say that this patient has cognitive impairment and whatever you do, you're not going to get the outcomes unless you have someone who can help us help the patient overcome the cognitive issues. Right? So only then our interventions will have some use. Right? Similarly, the patient's outcomes are more important than what you as an individual can do to the patient. So to make interdisciplinary teams is a big challenge because it is not easy to get them marketed. It's not easy to afford them marketing. At least in organizations like universities like Diamond Circle and Manipal and Ramaya, such places, we're able to make some effort to make it happen, but not completely successfully. But the future is having multidisciplinary teams for the good of the patient. Right? That's what I want to say.
Thank you, sir.
I just want to add up to what Sarthi sir was telling and what Tushar Parkar sir was telling, and your question was interdisciplinary research. I personally had this two experience where in nursing faculty came up with talking about giving ultrasound for wounding. First, this is one instance. In second instance, an MTech engineer student came and asked her, I want to know you're working with ultrasound for pain treatment. I want to know how ultrasound works. When first they came up and asked me this, I was sitting back. I was thinking, why is he asking about my field? Why is nurses coming asking about what I can do with ultrasound, or why is MTech person is asking about construction of ultrasound? Then also I thought that okay, there are people who are looking into interdisciplinary research and they want to know how best ultimately the outcome of is the patient has to be helped relieving his whatever his disability, and also the normal people should be cured of their problems. So that kind of interdisciplinary research is very important in improving the treatment part, assessment part, rehabilitation part. As in physio, we always we get stuck into talking about very costly instruments for treatment, measuring outcomes. So probably collaboration between this interdisciplinary researchers and outcome of researchers could be very useful in our field. That's what I feel.
Thank you, sir. So now from our young generation, any question to our panelists about professional development? Sai Kumar sir, can you give any advice for young generation?
Young generation, only advice would be do not be restricted to the curriculum and be clear with what you want to do. And we, as a physiotherapy professional, we have grown enormously from what we have seen past 2-3 decades. We, as the students from 90s, to know what we are seeing after 3 decades. It's like humongous change as we had. So something of physiotherapy, podiatric physiotherapy, as Rishikesh sir was talking, was something which was unheard of. And the specialty is what we are now establishing. Like we have OBG specialty, women's health as a specialty masters here, geriatric physiotherapy as a masters. These are all specialties which we never heard or thought about that may have a role to play in all these areas. The only areas we were thinking about is musculoskeletal, neuro, cardio. But you people as an young generation have to expand your thought process beyond our conventional methods and think what you can do or how you can contribute with your innovative methods of thought process. And as one word I put functional outcome, I stress on this because as we are talking about the very important topic about additional courses, I myself is an example for this. At this experience, I pursued a doctorate in physical therapy recently from Montana University, and I just finished recently. I'm speaking this because of my own experience. There was no need for me to pursue that course with my current position or career point of view. It doesn't make any difference in my position or growth professionally. But personally, there was a lot to learn from that course, from those universities, how they approach and what is the method of planning towards a physiotherapy case or towards a patient, and how is the process happening. And that is when I realized after so many years of experience, I don't know anything. I mean, we are still lagging behind a lot. And as a physiotherapy profession, we don't have that specific tasks or goal-oriented planning. So that is very, very essential. And that is why I said quality of life and functional outcome. So I doubt whether you people really understand what is a functional outcome. Okay, so we always think about treatment as only relieving pain, improving mobility, strength, flexibility, endurance, all these things. Yes, these are essential. But how much is essential for a person's the actual functional requirements which he has to deal with? And that is how, when you focus, that is when you get a realistic outcome which a person puts into his real practice and quality of life. So this is a process which you need to follow, and that process is very, very essential, irrespective of the specialty you choose. And that is the reason you finish your bachelor's, you finish your master's, it doesn't end there. You pursue, but you have to be very wise enough, as Mark sir was telling, there are so many courses now offered, so many certifications, but you have to be wise enough, take proper guidance and advice which is required, which is essential, and not necessary that you have hundred of certificates with you and say that I have pursued so many courses. That doesn't make any use or it will benefit you. You have to be focused with only what is your area of interest and how to expand the knowledge in your area of interest. Do not focus into other areas and do not bother about, like, there's another case which probably I miss out, it will go to the other adjacent clinic, so it doesn't matter. So if you focus properly on your area, tomorrow you will have all the patients related to your area starting at your doorstep. So that is what you need to focus, and comes with quality practice, and it comes with expanding your knowledge by knowing what is happening across the world. Okay, so everyone have different approaches, and try to learn, try to read, try to attend various courses, and then take the positives. Okay, so that comes with experience by attending various talks, presentations. Probably we are sitting here not knowing all these things at our college level. Probably this is out of experience after probably 20 years, 20 plus years. And this we have gained with experience. So we don't want you to gain this after 20 years. We want you to gain knowledge. So that is probably the ultimate motto of this panel discussion.
Thank you, sir. That was the most valuable message to our young generation. So, in the closing remark, I just want to say yes, continuous education is very important for a professional development. You should continuously grow professionally, and for that, yes, take the courses, academic courses, because just as sir said, just don't stick on to your curriculum. Take courses, but take of your interest. Don't go beyond the credits. Choose your area and just keep exploring. Okay.
Of course, our education policy, as per our curriculum, we need some changes, and the changes has to be based on the functional outcome. As sir said, yes, we need a quality publications, not just a quantity. And whatever publication we are doing, whatever research we are doing, that should have a good implication in the patient care. When we are doing interdisciplinary collaboration, interdisciplinary research, our main focus should be for a betterment of a patient health. Yes, and one most important thing is, yes, you keep exploring, keep exploring. Journey is important, not the destination. Thank you.
Hello, so we have one more question, Dr. Sophie.
One question. Being like teacher, what we can do to improve the quality of research for ourselves and for our students? What things we should consider that our research quality should improve?
Glad that you were part of that one. So all of us forever have to be open to learning things, right? Want to pursue research, we need to learn, we need to work towards to understand how to do research. I think some of the universities are conducting a lot of courses on research and statistics, right? That would lay foundation to understand how to do the research. Because when we don't know what is the right kind of research, we will do anything that is available to us, and because we don't see that to be a wrong way or wrong approach. Because we know that much to do. So let's find ways to understand what is the right kind of research. Why do we have to do research actually? So how is it going to impact? Yes, of course, professional growth is very important, right? Along with that, your research should actually impact the society. So for that, understanding how to do research, biostatistics is one important thing. And other important piece for physiotherapists is as a academician, madam. As an academician, if you don't touch the patient, if you don't treat the patients, how will you find the research problem? You will not find a research problem, right? Because we have the theoretical knowledge. You cannot derive the research questions because based on the theoretical knowledge that we have, we can only do some observation studies, of course, but to create an impact, we have to do interventional approaches. So for that, we have to see lots of patients in the area of interest that we want to work on, and then pursue research in that particular direction only, that particular space. Let's say I'm doing one research in the shoulder area. Next, I find somebody who wants to interested in me, yes, here we have something to that. We switch over to that, and then randomly go for some research. Then we are not having connectivity to your continuous research. If you work in one area, I'm not saying that it's not a multiple parallel research programs, but to dwell where, if you want to really cause an impact, choose one area of your interest, one or two areas, and try to pursue that a little more in depth. Associate with people who are into that research area. Talk to them, collaborate them, have them as a research partner, different institutes or wherever, right? So then that will create impact. We will learn from others who are already put in that space. Stand, bring the research with good friend, hey, let us do something like that. Is that okay? Let's not be not a good piece of work, right? Let's say if you want to do, for example, focuses on education, you want to work on foot, please connect to him because we know that attending such conferences, you know who is good in which area. Take their help, ask them to partner with you. Then that become a master in that space. Then you can guide your students how to do the research in a particular direction. So these are my simple thoughts for
Yes, as Partha sir was pointed out, how good research can be done. What my experience as a mentor, a guide, what I feel is people are very good in our people are very good in doing research and getting results. Everything is fine. But where I find the lacking is finding the research gap or any research question. Why they want to do that? Okay, it's not so important your methodology is this or that. Okay, your gap or you're correlating the mathematics or something. Why you want to treat that research gap is very important. So spend more time on literature survey and things like that. Point out why you want to do this research. What was the research gap? What you feel in this. So then your research could be very good and outcome could be very good. This is what my suggestion.
Thank you, ma'am. On behalf of the National DSU Symposium, I would like to extend my deepest gratitude for your exceptional role as the moderator for our panel discussion. Your expertise and insight questions added tremendous value to this discussion. We appreciate the time and effort and dedication to ensure a dynamic and engaging session. I would also like to thank Dr. Vinod, Dr. Sai, and Dr. Partha. Thank you very much for your significant contribution to this discussion and your insight and expertise and your thoughtful perspectives greatly enrich our discussion. Now I would request I would also like to thank Dr. Tushar Palekar, Principal, DY Patil, Pune, for his significant contribution in this discussion. Being online, sir had been very cooperative and he was very answerable to all the questions. So I thank you for your expertise, sir. Now I would request Dr. Radhika ma'am to give away the mementos to our panelists. Now I will request Dr. Satya Prasad to give Radhika ma'am the award. Thank you, Radhika ma'am. Thank you, sir. Thank you, panelists. Now moving on to the last session, which is the prize distribution, the most awaited session by all the delegates here. So now I would like to announce the prize winners for scientific paper presentation, starting from the PhD and academic category. Second prize goes to Dr. Priyanka Amit Kumar from Garden City and Dr. Purvi N. Raj from Prudence College of Physiotherapy. My request is the delegates are here, please come forward, collect their certificates. Under the category of PhD and academician, second prize goes to Dr. Priyanka Amit Kumar from Garden City University and Dr. Purvi N. Raj from Prudence. I call Dr. Vinod on stage to give away the certificates. First prize under the category PhD and Academician goes to Dr. Sripala Pallavi from Sri Ramachandra Institute. I call upon Dr. Sai to give away the certificate. Give away number. Moving on to the next category, that is postgraduate. Second prize goes to Syed Hossain. Dr. Rishikesh to come over the stage to present the certificate. Syed Kosi and Sanchita Chatterjee. The first prize for the postgraduate goes to Reena Prakash from RD College. Any delegate, if you're there from RD College, please come forward and collect the certificate. Moving on to the next category, undergraduate. Second prize goes to Rukaya Vishwa. Also, I call upon Dr. Shweta to present the certificates. Amrita A, second prize. Okay. First prize under UG category goes to Sharada Suresh. The first prize winners will be receiving a cash prize. I request you all to please contact the scientific committee for the same. Now, moving on towards significant contribution given by each colleges. We are thankful as the committee for participating in PSU National Symposium and making it a success. I would like to thank East Point College of Physiotherapy, Dr. Rupa Lokesh, for her significant contribution.
I request students from college, any student from this East Point College to collect the memento. I request Principal Satya Guru sir to please give away the certificates. I would also like to thank NR Acharya College for their significant contribution. I would like to thank Dr. Marika Arjun. I request one member from the college. I would like to also thank RD College of Physiotherapy, a special contribution by Dr. Prithvi Raj. I request one of the student delegates to please come forward. I would also like to thank Oxford College of Physiotherapy, Dr. Vasant. I request any student delegate to please come forward and collect the trophy. I would also like to thank Vemana College of Physiotherapy, especially Dr. Pradeep Reddy. I request if there is any student delegate to come forward and collect the memento. I would like to thank Ramaya College of Physiotherapy. If any delegate is there, I request them to please come forward and collect the memento. I would also like to thank STM College of Physiotherapy, Dharwad, Dr. Sanjay Parker. I request the student delegate to come forward. I would also like to thank Prudence College of Physiotherapy, especially Dr. Shweta for her significant contribution. Now we have our two advisory committee members who had significantly contributed to this event. I would like to thank Dr. Danish Kumar, Principal, Nikkei Institute of Physiotherapy, for his significant contribution in the advisory committee and to be a part of today's symposium. I would also like to thank Dr. Sai Kumar for his significant contribution as the advisory committee. Thank you, sir, for being a part of the symposium. Thank you, ma'am. Now I would like to call Dr. Sanju for the closing remarks.
Good afternoon, dear delegates. As we draw the curtains on the DSU National Symposium 2024, theme from soul to soul, taking step towards better health. I'm filled with immense gratitude and inspiration. Over this past 2 days, we have embarked on the incredible journey exploring the pivotal role of physiotherapy in promoting the holistic health and well-being. Our symposium has been a confluence of brilliant minds and dedicated professionals all united by a common goal to enhance the quality of life through innovative practices and approaches in physiotherapy. The insights shared, the discussion held, and the connections made here will undoubtedly resonate far beyond this pause, influencing our practices and perspectives in profound ways. I would like to extend my deepest thanks to our esteemed speakers, whose expertise and passion have enriched our understanding and opened avenues for advancing our field. To all the attendees to various colleges, your enthusiasm, curiosity, and your engagement and your active participation have fostered a vibrant atmosphere and making the symposium a truly successful one. A heartfelt thank you to our organizing committee and the volunteers who have worked tirelessly behind the scenes. To our sponsors and the partners, thank you. Thank you for your unwavering support and belief in the vision of this DSU National Symposium 2024. Your contribution have been essential in making this event possible and impactful. As we conclude, let us take with us the knowledge, inspiration, and the connections we have gained today. Together, we can continue to advance the field of physiotherapy and make a lasting impact on the lives of those we serve. Let's commit to taking steps, both big or small, towards better health from soul to soul. Thank you once again, everyone, for being a part of DSU Symposium 2024. Have a great day. Dear delegates, so tomorrow we have the post-symposium workshop. As you all are aware, you will be informed about what all things you have to get in. So tomorrow, please be on time, same venue. Get your kits. Again, I request you all to be on time tomorrow in the proper attire. Now, I would request, we'll have a tea break now, tea session. At the same time, we'll be giving you the public book publication, soft copy, along with the ISBN and the DOI soon, which you'll be receiving after a week via your mails. So I thank you all to be a part of this DSU symposium. Now I request you all to please proceed for the meeting. I request you all at the same time to please fill the feedback form. The feedback form has been sent in your WhatsApp group. I request you all to please fill the feedback forms. Thank you. I request all the volunteers, the student volunteers, to gather here on the stage. I request all the student volunteers to gather here on the stage as soon as possible. Tea and snacks have been arranged